I think we can start now, madam.
Good afternoon and welcome to this unique webinar on cardiac pharmacotherapy, which is organized by IMA Pune in association with AstraZeneca. Prominent speakers like Dr. Sumit Agarwal, Dr. B.B. Halke, Dr. Amit Zinker, Dr. Yaman Kokre, Dr. Rajesh Wad, and Dr. Yogesh Kadam will be discussing diabetes with coronary artery diseases and cardiorenal complications and its management in cases. With case study. Before we start the webinar, there are a few announcements I would like to make regarding IMA Pune forthcoming events. Please register for them. With this, on this Sunday, on the occasion of Foundation IMA Pune Foundation Day, we are having early morning. There is a Foundation Day run and walk. It will be on 29th May at 7 a.m. Probably it will start at 6:30, so we prepare there at 6:30. And then in the afternoon from 9 o'clock to 4 o'clock, there will be a CME on Tobacco Free India on World No Tobacco Day. Then in the evening, there will be a melody orchestra, which will be with romantic old hit songs of Bollywood with live musicians and surprise performances by our IMA members. So it is free for all members. Then on 5th of June, there is again that 94th Foundation Day celebration. So we will be having Rangoli and cooking competition from 10 to 12 in Karaste Hall, and on 2 p.m. onwards, there is a Rangaram Vivid Gunadarshan with prize distribution at the end. And in the Shelter Hall, we will be having art exhibition, painting, photography, jewelry, pottery, and creative art. It will start from 12 p.m. to 5 p.m. So it is free for all members, but free registration for participants is mandatory. So with this, we'll come to our today's webinar. I will request Dr. Meenakshi Deshpande, our President, IMA Pune, to give her opening remarks. Everybody, I hope many have joined and are still in the process of joining. So let this process continue. We will just talk about little bit about IMA before going on to the webinar. Today's webinar is on cardiac pharmacotherapy, which is given by AstraZeneca. So we thank AstraZeneca for giving us monthly webinars on such beautiful topics with a faculty of esteemed speakers or indoor speakers we are having every month to tell us about the new drugs and the new cardiac problems which we face in our day-to-day practice. In IMA Pune presently, we are going to have an IMA Foundation Day celebration program from the next weekend onwards. So I request all of you to be there and attend all our programs either as a participant or as an audience, so that you come here to IMA Pune building and we will be happy to receive you all. Second thing is, we are having on occasion of World No Tobacco Day, we are having the first time ever a full day CME on all related to tobacco and this prevention of addiction. So for this also, I request every one of you to register physically, because this is going to be a physical event in which we are going to do a spirometry on the spot testing of all the delegates, even of the public. So we are going to publish a sort of report in the next day or on the World Tobacco Day. So I would request all of you to register, come and attend this event also on this coming Sunday, 29th of May. Next to this evening, Dr. Alka has already told you about the orchestra which we are having on the 29th May evening, which is free for all IMA Pune members. This is also the first time ever that we are having a free orchestra for IMA Pune members for our Foundation Day celebration. On 31st May, we are having yet another program. It's a very small program between 4 to 6 p.m. We are having our own Dr. Ravinath Godbole speaking on his accomplishments in Mount Everest trekking. And it is going to be a 45-minute lecture video demonstration and a accompaniment of the chief guest is none other than Mr. Raghunandan Lele. So I would request you all to come, one and all, on 31st May at 4 p.m. to IMA House at Sympathetic Hall. So with these words, I will.
Ma'am, hello. Ma'am, your voice is not clear. It's disturbing a lot.
Oh, now you are very near to the mic actually. There's no problem. Can you hear me now?
Yeah, now somewhat better, ma'am.
There is a lot of disturbance and noise in the voice. Very much noise in the voice. We can hear you, but it's noise in the voice. Probably microphone problem might be there.
I'm trying to change the whole setting also now, but can you hear us now? Now is it okay?
Yeah. Okay, continue.
Yes, now it's clear, sir.
Start with the actual webinar with the introduction of the speaker. But what I was telling you is, you please attend all the programs which we are sending out as WhatsApp messages to you all on 29th of May and on 31st of May. That's all. Thank you. Thank you, madam. Thank you, Dr. Padma madam, and Dr. Mr. Virendra Padwar, they are joined from Team Academica, So, we'll be introducing our first speaker, first batsman, Dr. Sumit Agarwal. He's an MD physician and diabetologist. He's having a fellowship in diabetology. He's working as a consultant physician and diabetologist at Mai Mangeshkar Hospital, Jahangir Specialty Hospital, and Agarwal Hospital. Also, he has worked as principal investigator in multi-phase IV clinical trials. So, with this introduction, I will hand over the mic to Dr. Sumit Agarwal. His topic is diabetes with coronary artery disease managing early adult age. So, over to Dr. Sumit Agarwal.
Thank you for the kind introduction, madam. And good afternoon, everyone. I thank IMA and AstraZeneca for inviting me as a speaker. And I also welcome all the attendees who have joined today for today's session. So I'm Dr. Sumit Agarwal. I'll be speaking about diabetes with coronary artery disease. Managing early has an edge. This is a guy around middle age, 35-40 years old, Vijay, who's newly diagnosed type 2 diabetes. He's worried about his heart and blood glucose levels. So I'll just give you his background. This guy has a HbA1c of 8.4. His BMI is 24.
Sorry, sir. Sorry to interrupt you. Sir, screen आपली दिसत नाहीये.
Screen दिसत नाहीये.
हाँ.
दिसतीये? Screen दिसतीये का?
नाही sir, अजून तर नाही. नाही sir, not yet.
Now is it visible?
Yes sir. Now
yes, it is visible.
Yes sir. Yes sir. Clear.
Thank you. Okay, so
please start on the left side.
Yeah. So this guy is a middle-aged and a 35-40-year-old patient who is newly diagnosed type 2 and is worried about his heart and blood glucose levels. Just to give his background, he has a HbA1c of 8.4%. His BMI is 24 kg per meter square. His blood pressure is 136/92 millimeters of mercury. His total cholesterol is 210, while his LDL cholesterol is 165. He has history of unstable angina. His eGFR is 70 and urine albumin creatine ratio is 50. So now, if you look at this guy, he's actually right. He should be worried about his heart and glucose because his blood pressure is on the higher side. His HbA1c is 8.4. His cholesterol is high, and he is a perfect cocktail to get what we all fear, that is coronary artery disease. He also gives a history of unstable angina. So what can be done? Okay, so diabetes and coronary cardiovascular diseases. Diabetes affects heart and blood vessels and may cause fatal complications such as coronary artery disease and stroke. People with diabetes are 2 to 3 times more likely to have cardiovascular diseases than patients without diabetes. This is very important, and all diabetic patients should be educated about this. diabetes and cardiovascular diseases are currently among the leading cause of morbidity and mortality worldwide. The negative effect of diabetes and cardiovascular diseases are accelerated by globalization, rapid unplanned urbanization, and increasingly sedentary lifestyle. People with diabetes should work with their health professionals to improve their diabetes management, as well as seeking support to stop smoking and implement sustainable improvement in their diet and physical activity. So basically, diabetes and cardiovascular diseases are very common, and it is a leading cause of mortality and morbidity. And a diabetic is 2 to 3 times more likely to develop a cardiovascular disease as compared to non-diabetics. So what happens? Cardiovascular disease is the leading cause of death in India. CVD was responsible for nearly 28.1% of the deaths of all deaths. Along with diabetes, high cholesterol is a major risk factor for atherosclerosis. Lowering LDL cholesterol is a primary goal for treating patients with high cholesterol, whether or not they have a history of CVD. So all diabetic patients with dyslipidemia have to be treated aggressively in order to prevent them from going to having cardiovascular diseases. CV risk associated with diabetes. Now the left side graph shows a 7-year incidence of CV mortality in diabetic and non-diabetic patients, and you can see there is with diabetes, the risk of cardiovascular mortality increases significantly, even with or without prior MI. Now on the right side, there is a CV event rate which was linearly related to rising levels of cholesterol, and almost 4 to 5 times in diabetics as compared to non-diabetics. So patients who, as the cholesterol levels goes on increasing, the risk of CV events definitely increases, particularly in patients with diabetes. So diabetes with dyslipidemia just adding to the risk of cardiovascular diseases. So Indian phenotype needs control of both, that is coronary artery disease as well as dyslipidemia. Managing coronary artery disease and sympathetic overactivity. Stress continues to affect Indians. This was a 2018 Sigma study, 360-degree well-being survey, which ended in 2020, and which showed 9 out of 10 of the Indian population say that they are suffering from stress, compared to the global average of 86%. So in India, it is almost 90%. 3 out of 4 are not willing to talk about their stress with medical professionals. Almost 50% of the Indians feel they do not spend sufficient time for social activities with friends or hobbies due to work. Or about 50% of the Indians are not confident about taking care of their family's financial needs. And around 2 out of 5 people, that is 39% professionals, are experiencing increased stress or anxiety due to COVID-19. So stress definitely has affected Indians as compared to the world data. This is what the survey said. More than 62% of the Indian hypertensives have sympathetic overactivity. Prevalence of sympathetic overactivity in Indian hypertensive is almost 62%. Along sympathetic overactivity is further elevated in patients with diabetes, smoking, and obesity. And so patient with hypertension, almost 62% have high sympathetic activity. Particularly patients with diabetes or who smoke or who have obesity, the sympathetic overactivity is further elevated. Sympathetic overactivity is associated with increased heart rate and multiple cardiovascular risk factors. Now, if you look at the flow chart, sympathetic activity causes vasoarterial constriction, decreases the muscle blood flow, increases insulin resistance, can lead to hypertension, can lead to lipid abnormalities and coronary events. Also, because of increased sympathetic overactivity, the oxygen consumption is increased by the heart, can lead to ventricular arrhythmias, which can lead to heart failure or sudden cardiac death. Increased sympathetic activity also causes increase in heart rate, causes increasing arterial wall stress, endothelial dysfunction, and atherosclerotic plaque formation. Also, LV apoptosis, increasing collagen fibrosis, LV stiffness, and LV systolic dysfunction, all leading to heart failure and sudden death. So basically, sympathetic overdrive has to be controlled in all these patients to prevent from coronary events, heart failure, or sudden death. So diabetes can activate the sympathetic nervous system. Type 2 diabetes increases insulin resistance, increases insulin. This leads to increase in non-epinephrine levels. With increase in non-epinephrine levels, there is an increased risk of ventricular arrhythmias, and also there is increase in plasma renin activity, which can further increase the norepinephrine release. Sympathetic activity. This is patients with hypertension, diabetes, and normotensive patients. You can see the sympathetic activity is more in patients with hypertension and diabetes together, and it is also increased in patients with diabetes alone as compared to non-hypertensive patients, normotensive patients. Patient continue to experience one or more symptoms every day and are higher risk of coronary heart disease. What are the symptoms of sympathetic overactivity? Patient can feel tremors in hand, fast speech, restlessness, inappropriate sweating. These are symptoms of sympathetic overactivity. Elevated heart rate increases the risk of CHD mortality in patients with less than 55 years of age. It is almost 2 times more. So as the heart rate increases, the relative risk of death is increased, which is seen more with heart rates more than 100. So this is beautiful study. Patients with heart rate more than 70 had increased risk of cardiovascular death, admission to hospital for heart failure, admission to hospital for myocardial infarction. This beautiful study was included more than 10,000 patients with coronary artery disease and left ventricular systolic dysfunction. The vast majority of patients received other CVD drugs recommended by the guidelines with a median follow-up end period of 19 months. The primary composite endpoint included cardiovascular death, admission to hospital for acute myocardial infarction, admission to hospital for new heart failure or heart failure exacerbation. So basically, this study concluded that heart rate with more than 70, there is increased risk. So beta blockers are recommended as first-line drugs in special scenarios where they are combined with any of the above class of drugs, that is calcium channel blockers, ARB or AC inhibitors, or thiazide diuretics, when there are specific clinical situations such as angina, post-myocardial infarction, heart failure, or heart rate control. So basically, if you look at the guidelines for hypertension management, beta blockers don't come in the first line drugs for hypertension management. But when there are special conditions such as patient is post angina, or patient is post myocardial infarction, or patient has heart failure, or his heart rate is remaining above, resting heart rate is remaining above 80, he is a candidate to receive beta blockers as first line drugs for hypertension management. Role of beta blockers in coronary artery disease: increase heart rate and cardiac contractibility, increases myocardial oxygen demand. So beta blocker inhibits the sympathetic stimulation, reduces sympathetic stimulation, reduces heart rate and cardiac contractility, thus reducing the oxygen demand of the myocardium. Managing symptoms and risks with metoprolol. Metoprolol reduces sympathetic overactivity. It almost reduces heart rate by 14.53 beats per minute. This is the average reduction of heart rate with metoprolol. Metoprolol is a beta-1 selective beta blocker. Metoprolol is rapidly and completely absorbed throughout the GI tract, including distal region. Half-life is around 3 to 4 hours. Excretion is through hepatic route. No accumulation of drug in late-stage kidney disease. So the advantage, it can also be used in stage 4, stage 5 CKDs, and there are no active metabolites. Metoprolol reduces the risk of all-cause death and also sudden cardiac death. So if you see the use of metoprolol as compared to diuretics in all-cause death, there is almost 22% reduction in the risk reduction with the use of metoprolol as compared to diuretics for all-cause death. Also, in sudden cardiac death, there is almost 30% risk reduction with the use of metoprolol. Choosing life with unique MUPS ZOC technology. Now, the metoprolol, what we are talking about is silocaine XL sustained release. Normally, sustained release formulation, sustained release formulation are made in 2 forms. Either it is a gel-based matrix system. The rate of drug release depends on concentration of drug in the tablet. May not be ideal since it is more than 90% of the drug is released in first 10 hours. Now, the tablet we are talking about, silocaine XL, it is made by MUPS ZOC technology. So MUPS stands for multi-unit pellet system based on ZOC. Gives desired constant plasma concentration for 24 hours. Now this is the tablet form of MUPS. These are pellets, microcapsules, and they are put together in a tablet. Each tablet releases around several hundreds of micropellets with a diameter of 0.5 millimeters, covered with insoluble pH independent polymeric membrane. Multi-unit pellet system. Slow release matrix tablets do not disintegrate. The entire dose is consequently contained in one single unit during GI transit. So each of the micropellet acts as a diffusion cell, constant release of metoprolol from the pellet during the 20 hours of period, absorption during at least 20 hours throughout the whole GIT. So pellet design renders the release of drug unresponsive to change in physiological conditions during the release period. Now this is it was tested with different meals, different pH, and with agitation, and it was found that the release of silocaine was not affected by meal or pH or by agitation. So advantages of silocaine XL: it's once daily administration, so it is better compliance as compared to the other brands available, where the half-life is less as compared to silocaine. Therapeutic plasma concentration is smooth and uniform throughout the 24 hours. Higher beta-1 selectivity and less side effects. Higher degree of response among hypertensive patients, so better tolerated. And ethyl cellulose polymer outer membrane prevents the impact from physiological factors such as food intake, pH, body fluids, and intestinal motility. Absorption is not interfered by food or intestinal fluids or motility or in the GIT. So basically, it is a better formulation as compared to other competitor brands. So how can we ensure better efficacy or outcome? Choosing the innovator and research agent. Almost expected efficacy range in non-innovator agent compared to the innovator agent. You can see almost 20% reduced drug efficacy and almost 25% increase in side effects with the non-innovator molecule as compared to the innovator molecule. Now this I am talking about atorvastatin. The presence of methylated impurity in generic. A methylated atorvastatin impurity was highly conserved in generic atorvastatin formulation. This impurity was shown to have no inhibitory effects of HMGR enzyme activity. The presence of this impurity is widely available version of generic atorvastatin may compromise global effort towards the effective management. So if there is such high impurity, the cholesterol lowering effect or atorvastatin is reduced with the generic atorvastatin, and then the desired effect or the reduction in CV risk cannot be attained. Compared to the innovator statins, the probability of suffering a cardiovascular event for generic was higher with an average of 31%, which is very high. So, to summarize, sympathetic overactivity is further elevated in patients with diabetes, obesity, smoking, and stress. Elevated heart rate increases the risk of CHD mortality in patients with 55 years by almost 2 times. Metoprolol helps to reduce the sympathetic overactivity by reducing the heart rate by almost 14.53 beats per minute. The risk of sudden cardiac death is reduced by 30%, and all-cause mortality is reduced by 22% in patients with coronary artery disease. Metoprolol with MUPS prolonged release formulation provides almost 24-hour duration of action, with its absorption being unaffected by food intake, pH of body fluids, and intestinal motility. Thank you.
Hello. That was a nice talk, Dr. Sumit Agarwal. I think everybody is spellbound. Are there any, yeah, now you can take up the questions if there are any.
Yeah. So it was a very informative lecture.
Dr. Alka, there is really a problem with our speaker over there. We cannot hear you.
You can't hear? Right?
We cannot hear you.
Is it audible now? Is it audible now?
Not very clear. Ask Aniket to come.
Good afternoon. Aniket.
Lot of echoing sound is there, Dr. Alka. You know, it's very much echoing sound is there.
Till then, I'll just see if there are any questions in the chat box.
Yeah.
And Dr. Padma Madam, are you having any questions till then?
No. I think whatever he has spoken about the efficacy of metoprolol.
It's quite clear.
Very, very clear. Yeah. Thank you.
Okay. So, Dr. Alka, can you just announce the felicitation? We'll felicitate Dr. Sumit Agarwal.
Alka Madam, unmute yourself and go ahead, please.
I don't really know what is the problem, but I think everybody can hear me.
Yeah, yeah.
So
You
Dr.
are very
Sumit
clear.
Agarwal, here is the Uparna for you
Thank you so
from
much,
IMA
madam.
Pune and a bouquet for you. And thank you for a wonderful lecture. It was really good, and I think it was such a you have put on the topic so comprehensively well that it was totally understood by all the delegates. That is why there are no questions. So thank you so much, and we would really welcome you to IMA. Come physically to IMA anytime you want, and especially for our programs. Yeah.
Thank you, madam. So now we'll go to the next speaker, and with me, Dr. Virendra Ostwal is with me to moderate the session. He is a spine surgeon and he's assistant secretary and joint treasurer of IMA Pune. So,
thank you, madam. Good afternoon, everybody. After the first talk by Dr. Sumit Agarwal, we have a second topic on from prevention to treatment of cardiorenal complications of diabetes. The speaker for this is Dr. Bhaskar Hfref. I take this opportunity to introduce Dr. Bhaskar Hfref, sir. Dr. Bhaskar Hfref is MD Medicine and Diabetologist. He is a consultant diabetologist at Pune Hospital, and he is a Joint Secretary of Diabetic Association of India, Pune branch. Dr. Hfref has participated in several state, national, and international diabetic conferences as a delegate as well as faculty. Sir has also conducted and designed public educational and awareness programs in diabetes, including stage shows, dramas, lectures, public speech, and articles in print media. He has authored. He is the author in Advances in Diabetes Management, a Swiss Compendium 2015, and dedicated international textbook on diabetes 2017. He is also a recipient of Scroll of Honor and by PHFI for consecutive 4 years for conducting certified course in diabetes for medical health professionals. With this short introduction of Dr. Bhaskar Hfref, I invite Dr. Bhaskar Hfref, sir, to talk on topic from prevention to treatment of cardiorenal complications of diabetes. Over to Dr. Hfref, sir.
Yes, thank you. Sorry?
Sir is known as Dr. B.B. Hfref.
Yes, thank you. Thank you for a nice introduction, and thank you for giving me an opportunity to share my views about management of diabetes and conceptual changes in management of diabetes on this IMA platform and to the IMA authorities. And I'm also thankful to AstraZeneca to select me as a speaker for this program. So with this, I'll share my screen just a moment. And can you able to see my screen now?
Yes, sir.
Yes, yes. Whenever a diabetic patient presents in the clinic, just think yourself, what thoughts came in your mind? Or prevent the complications. If you are Can you hear me? Hello?
Yes, sir, we can hear you.
Yeah, I was out of this thing. Suddenly some net problem. So whenever patient of diabetes presents in your clinic, what thoughts came in your mind? What to address first? Glycemia, lipid abnormalities, protein metabolism, or organ protection? Currently, the trend has definitely changed, and the pendulum shifts from the managing glycemia to the managing organ protection also. Not only that, certain drugs which are added in an armamentarium, which are used to prevent diabetes in high-risk cases as well as pre-diabetic cases. One of them. So we are going to listen, or we are going to
So your screen sharing has stopped. So Harshay sir, please unmute yourself. Harshay sir?
Yeah. I think I'll shut off my video. Probably the net connection is giving me a problem. So now you can hear me nicely? Yes. Yes. And now I'll reshare my screen again. One second. Yeah. Everything is fine now?
Yes, we can hear you.
I hope
We can see you also. Yeah.
You can see my screen also? Can you see my screen?
Yes, we can see your screen, sir.
Yes. So SGLT2 inhibitors are one of them, the molecules which are definitely can help this thing. So what typically we have a typical patient presents in a clinic with a cardiorenal metabolic risk continuum. Diabetes, you know, you are aware, they are initially undiagnosed for many years. When it gets first diagnosed, he may have associated risk factor or early, or he may not have any associated risk factors. So early in a natural history can be diagnosed. Another set of patients where you can diagnose patient with a multiple risk factor with severe renal complications or threats to the developing complications. And so another group of patients you can see with established CV and renal complications. So in all three groups, you have a scope to select the drug, to use the drug and properly, and you have a scope to So you have a scope to address these all complications properly and prevent the further damage. And primary, secondary prevention, is it possible? That's what we are going to discuss today. So as you are aware, the type 2 diabetes may have a presentation with fatty liver, may have a presentation with cardiovascular disease, heart failure, they have chronic kidney disease, and there is an overlap among all these 3 diseases, 4 diseases. And there is a subset of patients which are having all 3 complications together and which they carry very high mortality, which has been proved all worldwide. So the window of opportunity for cardiorenal prevention in type 2 diabetes, at what stage you have intervened, whether at the stage of late ventricular dysfunction or hypertrophy, or whether at the stage of new onset albuminuria, especially microalbuminuria, or way behind that. So what evidence says? The data has been collected from various registers it's a retrospective analysis from England, Germany, Japan, Netherlands, Norway, Sweden, etc. And all where everyone documented that first comorbidity identified in CV-free patients with type 2 diabetes is either CKD or heart failure, then followed by the strokes, IMA, and peripheral arterial disease. So compared with comorbidity-free patient with type 2 diabetes, cardiorenal disease was associated with greater risk of mortality than stroke, peripheral arterial disease, or MI. So these 2 groups needs to be addressed on priority basis among all the patients present to you. Even a patient present with a mild microalbuminuria, we say that these patients can be reversible to normal. Yes, that's true. But the hazard ratio or risk of mortality associated with microalbuminuria is just as equivalent to when you are facing with a CKD patient having eGFR 30 to 44, in between 30 to 44. So how grave it is, and that's you must understand there's significance of microalbuminuria, how on priority it has to be addressed. So where can we please place this DAPA in these cases to provide the window of opportunity to prevent cardiorenal complication that we are going to learn? Glucose lowering effect, decrease in microvascular morbidity, decrease in glucotoxicity, low risk of hypokalemia, that is well associated with SGLT2 inhibitors. And beauty of the molecule is that it is an insulin independent mechanism. There is no need of insulin to act like sulfonylurea to exert their pharmacological effects or therapeutic effects. So it can have ability to work at all stages of disease and combined with any other classes of drugs. We are among these anti-diabetic groups like insulin secretagogue, drugs acting on insulin resistance, or drugs which are promoting the decreasing the absorption of glucose. So you can combine this excretory glucose excretory drugs or glycosylate drugs at any class of drug. The osmotic diuresis is again a pleiotropic effect and which can be beneficial in a way to initiate weight loss and decrease in blood pressure and loss of excess calories in the urine or carbohydrate loss. That sustain the weight loss and mitigation of weight gain from other classes of anti-hyperglycemics. So you can combine these drugs with the other class of drugs. They either may be weight neutral or weight promoting drugs, and you can prevent the other adverse effects of the other drugs. If you look at this scenario that at various trials of HbA1c, baseline HbA1c was ranging from 7.92% to 9.42%, add-on with SGLT2 inhibitors with metformin shows definite reduction in HbA1c levels in 24 weeks duration. At higher trials of HbA1c, the drug was much show pronounced reduction in HbA1c, and that's as a biological rule. Similarly, you can, if you look at the left-hand side also, the monotherapy, add-on to metformin, add-on to sulfonylurea, add-on to DPP-4 inhibitors plus metformin, add-on to insulin and OAD, add-on to metformin and sulfonylurea, the dapagliflozin scores more, and it definitely augments the HbA1c reduction. If you look at the weight reduction also, patients with normal BMI also, they show around 1 kilogram weight reduction, and those with BMI higher than 40, there is definitely minus 3.4 kg weight reduction is observed in these patients. Weber's studies in patients with inadequately controlled diabetes and hypertension at 12 weeks show there is also associated reduction with the dapagliflozin as compared to placebo, and they're definitely drug also helpful in managing hypertension associated with diabetes. So in a short way, if you are looking at the three categories, that is the pipes are responsible for major adverse cardiovascular events, that is the atherosclerosis. Pumps, that is attributed to cardiovascular disease and hospitalized heart failure. And filters, their nomenclature attributed to the kidneys also. So use of this drug among dapagliflozin versus placebo is definitely show beneficial effects. Such patients who are having pre-existing MI less than 2 years ago, or they having prior MI also. But however, in asymptomatic cardiovascular disease who don't have prior MI or patient or subset of population associated with multiple risk factors, the pipe clearance or benefits of atherosclerosis, this is not observed. Still, there are in this class also, you have a benefit associated with pump failure and associated with the filters, that is the progressive CKD benefits. So if you implement dapagliflozin earlier in the scenario, you are definitely able to prevent the hospitalized heart failure events, or you can revert the renal damage in early stage. So that's the conclusion from type 2 diabetic population in Ticagrellar trial. So you have a window of opportunity to use this drug at any spectrum of population, starting from only the population with highest group, the population who have established cardiovascular diseases and having established kidney disease, definitely at early stage, between stage 3 to stage 1. So dapagliflozin reduces the risk of cardiovascular disease, heart failure, regardless the duration of diabetes. That has also been confirmed. Say the diabetes may be of less than 5 years duration or more than 20 years, you get the same beneficial effects, and renal specific outcomes was also reduced irrespective of the duration of diabetes. The adverse events associated and compared with the placebo or with the dapagliflozin in various broad severe risk population in a Ticagrellar trial, this which has population covered more than 17,000 patients for 4 years, the treatment emergence of serious adverse events, treatment events of adverse event leading to drug discontinuation, major hypoglycemia, diabetic ketoacidosis, amputation, fractures, acute kidney injuries, symptoms of hypovolemia, volume depletion, genital infection, urinary tract infection, Fournier cancer bladder. They are all comparable with the placebos. At certain places, they are significantly better as compared to the placebos. So that's why the dapagliflozin is backed up with the wealth of experience, and safety is well concerned. Safety concern is well addressed by this dapagliflozin. So in the story so far, you can say the drug initially invented for the glycemic control and avoidance of obesity and treatment of comorbidities like obesity, hypertension, etc. So accordingly, the guidelines also changed themselves, like AD and ESD and AAC in 2013. They initially start telling that you can use SGLT2 inhibitors with caution as a third or fourth line of vision. Then they changed their attitude in somewhere in 2018, and they started promoting secondary prevention. And now in 2021 or 2022, guidelines incorporate the latest evidence of SGLT2 inhibitors with high severe risk type 2 diabetic patients for primary prevention. So the studies with various SGLT2 inhibitors, they show the favorable effects with respect to primary heart failure outcome, with respect to renal outcome data, and reduction in heart failures with CKD prevention and cardiovascular output trials. So DAPA stands among all, ranks one among all remaining group of SGLT2 inhibitors, and DAPA is definitely promoted in diabetic and non-diabetic patients. So if you look at this is a little bit busy slide, but on your left hand side, you don't have any indicators of high risk or established asymptomatic cardiovascular disease or CKD or heart failure associated. On your right hand side, and on the left hand side, you have these patients included. So in that patient also, you can consider independently baseline HbA1c, individualized target, start metformin use if it is not contraindicated, and second add-on needs to be chosen as SGLT2 inhibitors, preferentially DAPA. So DAPA now takes up a role in management of diabetes and takes up a higher position. What next to metformin is probably answer in upcoming years. We may talk that it could be possible that DAPA can take that second add-on or primary drug for a monotherapy. So SGLT2 recommended independent glycemic control in patients with high severe risk, heart failures with reduced risk fractions, diabetic kidney disease, albuminuria, a part of established asymptomatic cardiovascular disease. So this is the SGLT2 current scenario with the various guidelines. Among all add-on therapies with DAPA, with metformin, you may their third choice may go to DP4 inhibitors. And among the various groups of add-on therapy or monotherapy, sexagliptin efficacy-wise or in combination with compared to the glycemic acid-wise, it stands better as compared to others. Statistical significance may or may not be there, but at least numerically it sounds better. However, the DAPA and SEXA, can it address the glycemic control and also address the adverse event label with the sexagliptin, that it is associated with increased hospitalized heart failures? Can it be tackled? So what data suggests here, if you look at the efficacy wise, SEXA, DAPA and metformin combination scores much higher in the baseline HbA1c reduction, even if baseline HbA1c less than 8, if it is in between 8 to 9 or more than 9, in all three groups, it scores way higher than the other two combinations. So that combination is definitely justified. What is the concern about the heart failure? If you look at the data available from the patient who are treated in SAVOT IMA trial 53, initially the heart failure association within first year of the treatment, it's a trial for 4 years, and first year of treatment, then definitely it carries high risk or hazard ratio is much higher as compared to the placebo, and sexagliptin is very high risk, considered high risk, and can cause hospitalized heart failure, much more patient. But however, as the trial progresses in subsequent years, this ratio is starts significantly decreasing, hazard ratio decreasing, but maintaining the difference between the placebo and and the drugs. So at present, I can comment on this thing. There's yes, it is the FDA and they initially definitely attribute this or attribute this drug for responsible for rehospitalization after responsible for the rehospitalization for the heart failure. But we need much more data to be screened out, and we need to come conclusion after the screening out or studying more, doing more analysis of various data coming out. So that's why on April 14, 2014, the FDA Endocrinology and Metabolic Drug Advisory Committee voted 13-1. One is absent, and 15 total votes. That results that several study demonstrated that the use of sexagliptin in patients with type 2 diabetes has an acceptable cardiovascular risk. So whether to accept or not, that's a debate is going on, and whether which should restrict or continue. So the voting and the debate is still going on. So at present, there are certain pro data and there is certain against data. So issue is yet to get clear. What is the role of treatment in prevention of cardiorenal complications like heart failure, reduced ejection fraction, and CKD, irrespective of type 2 DM? So can we use these drugs in type 2 DM or not? So here are two cases scenario. 70 years old male patient with obese patient with hypertension and long-standing type 2 diabetes, no history of heart failure, presented with dyspnea rate NYHA classification 4, and physically having signs of pedal edema, rals, crackles, elevated GV, classical signs of failure, pro-BNP high, ejection fraction is poor, albumin excretion creatinine ratio is 150. So, and there is EGFR, low EGFR. So this patient is having all three complications together: type 2 diabetes, heart failure, and the kidney involvement also, which carries high risk mortality also. And you have to address this patient, and AGLT2 may be a right choice in such patients. Second patient, he's a non-diabetic patient, 65 years old patient. He is coronary artery disease and hypertension, and Hfref, that is a heart failure, reduced ejection fraction 3 years back, with more than 5 hospitalizations last 2 years. So recurrent heart failure. The dyspnea on rest, NYHA classification 4, mild pedal edema was there, and NT-proBNP rate by 300 picogram per ml, decline in EGFR by 6 ml per minute per 173 meter square, and rise in urinary albumin creatinine ratio by 10%. So progressive CKD. So this patient can we use DAPA, and the recent guidelines say yes, you can use DAPA even in non-diabetic patients, and that's why the DAPA is getting more popular in cardiologists also, and medical fraternity who are not dealing diabetes also. They are also jumping to use this drug at in cases of heart failure. So heart failure is really a problem. Is global prevalence of heart failure is 63.6 million in 2016, which is increasing, and multi-center, multinational studies have suggested that 1 to 2% of people have heart failure. However, some single centers, national studies have reported much higher prevalence of heart failure. Despite of stable heart failure prevalence is increasing because of aging population, increased prevalence of comorbidities like diabetes and ischemic heart disease and CKD at the diagnosis of heart failure. So it becomes a major problem. So prevalence of heart failure is at least in India. What is the scenario? It's at least 8 to 10 million patients with heart failure in India, and it is about 1% of adult population. The post-admission mortality in India is 20 to 30% in heart failure cases. Medication adherence group ranges from 25 to 50%. That is very poor. The age prevalence of heart failure in patients was 22.5 below 30. So at younger age is much higher as compared to age 50, where it is 14.9%. So India is relatively young population getting affected by heart failures. The incidence of diabetes and heart failure in preventive heart failure registry was 54.9%. It's a single heart failure registry, which registered pretty high incidence as compared to the worldwide incidence. So how should we address this? What is the paradigm of heart failure composite CV deaths? So we have ACE inhibitors, but there are new drugs they are at the market now, what we call as angiotensin receptor neprilysin inhibitors, ARNI, when compared with the ACE inhibitors, and they show some about the 20% benefit in management of heart failure. However, still the residual risk definitely remains, and how that can be tackled is again a question. So DAPA heart failure overview, if you look at where around 5,000 patients have participated, 45% were type 2 diabetic, 55% were non-type 2 diabetic, and the DAPA has compared with the placebo group. The significant reduction in composite CV death and worsening of heart failure, it is 26% reduction in relative risk, and number need to treat is 21 to prevent CV death and heart failure. There's 18% significant relative reduction in CV deaths and heart failure, 33% reduction. So consistent benefits across the broad and representative population in both population, type 2 diabetic as well as no type 2 diabetes. The risk for both first and recurrent hospitalized heart failure events, reduction in all-cause mortality, and heart failure symptoms, they improve, and definitely significantly reduce risk and CV death worsening as compared to the heart failure. So it is DAPA HF safety. DAPA has well-tolerated patients with or without diabetes. Adverse events rarely lead to discontinuation of treatment, and no event measure hypoglycemia or decay in patients without type 2 diabetes. So you can safely use this drug in non-diabetic population also. Certain components are compared with the two SGLT2 group, DAPA and empagliflozin. With respect to the component studies are hospitalized heart failure reduction, CV death reduction, all-cause death reduction, then onset of new diabetes in pre and non-diabetic population reduction, ejection fraction, change in quality life score on KCQ or calculated 8 months for DAPA HF, 52 weeks for emperor reduce, and renal endpoints. So at various points, both drugs are quite comparable, but the significant difference between that CV death reduction is much more with a dapagliflozin. Then all-cause death reduction definitely observed with dapagliflozin. Then with this benefits, ejection consistent across the spectrum of baseline LV ejection fraction is well observed with dapagliflozin. The onset of new diabetes in pre and non-diabetic population reduction, which is also significant in DAPA group, except the renal endpoints, the 50% significant renal is benefit observed with empagliflozin, where renal deaths are excluded. If you include the renal deaths, then the statistic is not available. And with DAPA, there is 29% reduction, which may not be statistically significant. So both drugs are quite comparable. So at certain points, definitely the DAPA scores more as compared to the M. So the question comes around, how will you manage the heart failure with reduced ejection fraction? With what drug of choice? ACE inhibitors, ARNI, beta blockers, as Dr. Sumit Agarwal mentioned the role of beta blockers, then mineralocortical receptor antagonists, dapagliflozin, empagliflozin, and loop diuretics for the fluid retention. So additionally, the drugs recommended in all patients with heart failure are ACE inhibitors, beta blockers, MRA, that is a mineralocortical receptor antagonist, DAPA, and sacubitril and valsartan, that is the ARNI group of drugs. So if a patient presents to you, how will you manage the patient? So all group of drugs, start within the 4 weeks, you get beneficial effects. So not at every patient, you start with in step 1, you start with the beta blocker SGLT2 inhibitors. If you fail to achieve a response in a first week, then you add on strike with the ARNI group, but where you have to be sure that your systolic BP should not be less than 100. If it is less than 100, then you can add ARBs in the monitoring. Similarly, if your potassium is a hyperkalemia is a concern, you cannot start mineralocortical receptor antagonist. Then you have to select other drugs, or you can start a mineralocortical antagonist. So these are various guidelines whenever come across with a patient with heart failure. So whenever a diabetic or a non-diabetic patient with hypertension or without hypertension present and you suspect heart failure, get his echo done first, see his ejection fraction. If you are coming across with heart failure with reduced ejection fraction, say less than 45 or 50, you must consider the earliest intervention with certain drugs to address the progressive heart failure. And we have now a new pillar in our armamentarium, that is the pillar from dapagliflozin available. The scenario about the CKD prevalence is global prevalence 698 million and incidence is 19 million. In Canada and North America, the CKD prevalence is much higher. It is 14.44%, while in India, the prevalence is 6.76%. So, age standard global prevalence rate of CKD by cause per 1 lakh persons is diabetes contributes much higher to response for CKD, and it contributes about 42% of the CKD population. So diabetes causes the greatest rate of age standardized daily in patients with CKD in comparison with the other causes of CKD like hypertension, glomerulonephritis, or other CKD causes. And presence of CKD among the adults in USA depending on duration of diabetes. Longer the duration, higher the prevalence of CKD. Shorter the duration, lesser the prevalence of CKD. So various drugs have been studied to address such population and their beneficial effect in CKD. So ramipril range study, non-DM nephropathy, they have shown some benefits. AR-based irbesartan, losartan, olmesartan, now type 2 DM CKD, urinary protein excellent more than 900. So at some population has urinary protein, albumin creatinine ratio is more than 300, and type 2 diabetes and normal urine. In all three groups at various years, the trials proved certain definitely beneficial effect on CKD. While the other drugs or other class of drugs like ACE inhibitors and ARBs in combination on target, they are not favorable to kidney production. In fact, they harm the patient. Direct renin inhibitors like aliskirenine, glycosaminoglycan like sulodexide and anti-inflammatories, bardoxolone methyl. So these also experimental drug they have tried in various trials, but they have not proved any beneficial effect in preventing the progression of CKD or in fact regression of chronic kidney disease. DAPA CKD, the first treatment for the patient with CKD with or without type 2 diabetes, improve the cardiovascular outcomes and reduce mortality. So in DAPA CKD overview, around 4,304 patients have participated. DAPA 10 milligram and placebo around the distribution around 50-50%. And what the observations are, there is 39% relative risk reduction in composite sustained EGFR. To maintain the EGFR is more than 50% or equal to 50%, and no decline or any end-stage kidney disease. There is 36% relative risk reduction in patient with type 2 diabetes, hazard ratio 0.60, and 50% reduction that is in patient without type 2 diabetes. The dapagliflozin is well tolerated in keeping with established safety profile in all the two groups. So relatively, there is 44% relative risk reduction in composite outcome of sustained EGFR, more than 50% or equal to 50%, and preventing the decline and end-stage kidney disease or renal deaths. There is 29% relative risk reduction in CV deaths or heart failure, and there is 31% relative risk reduction in all-cause mortality with the use of DAPA. So trials stopped early due to overwhelming efficacy, and the results are consistent in patients in both subgroups of patients, diabetic and non-diabetic. First renal outcome studies show robust benefit on all-cause mortality, heart failure, CV benefits in CKD patients that established with DAPA heart failure are also observed. So demonstrate the ability to prevent and treat cardiorenal complications across the spectrum of diabetic kidney disease effectively by dapagliflozin. So coming to what latest guidelines in managing type 2 diabetes CKD. First baseline is physical activity, nutrition, and weight loss. First line therapy, if eGFR is more than 30 or equal to 30 ml, you can use metformin and SGLT2 inhibitors. If eGFR is less than 45, reduce the dose of metformin. Less than 30, or patient don't give metformin. SGLT2 you can safely give where eGFR is up to 30. Do not initiate SGLT2 inhibitor where the eGFR is less than 30 or on patient on dialysis, discontinue SGLT2 inhibitors. So rest of the patient, they can from stage 3 to stage 0, all patients, they can enjoy the benefit of SGLT2 inhibitors and metformin treatment in managing the kidney disease and patients with diabetes and non-diabetic groups also. Additional drug therapy as needed with glycemic control. If we need, you can add GLP-1 receptor agonists. They are most preferred drugs. TPP4 inhibitors, insulins are the second choice. Sulfonylurea, glitazones are caution, or in fact they are contraindicated, and AGI also they are to be used cautiously. So how you can ensure or how can achieve a better efficacy and outcome, better pharmacological? The most important consideration is to choose the innovator and research agent. And why this is important? That there are compounds which are called as pharmaceutical equivalents. They have a same generic compound content. They have, but their bioequivalence is not been studied. Their therapeutic equivalence is not been studied. And for cost-cutting purposes, they certain steps are omitted. So these medicines may, or what we call so-called originator and generic medicines, they may have contained some impurities or some inactive gradients, what we call excipients, and that may be different in different drugs, and that may affect the efficacy of the drug, and you may not get the desirable effect in a population. So that's why I always prefer to use a original brand or the brand which is bioequivalent. And I'm not saying it's a biosimilar, it's a bioequivalent, and that can, and which is well approved by the Food and Drug Administration of various nations. Like that's the case with the Glargine and the Westlaw. So at present, there is no other brand or bioequivalent brand available. So use the original brand dapagliflozin. And to summarize what we learned from lessons from three different trials, the Dicagrellar trial, DAPA heart failure, and DAPA CKD trial. So in asymptomatic cardiovascular disease, around 40%, and or other conditions like also where eGFR is around more than 60 ml. Heart failure reduced ejection fraction group, and CKD group. What we learn on that? So what we learn is glycemic status with diabetes is around asymptomatic group. They are with diabetic population study. In DAPA HF, 45% diabetic, 55% non-diabetic. With CKD, 68% with diabetics and 30% without diabetic. So mean eGFR in all groups is around ranging 85 to 43. Primary endpoint consider heart failure, CV deaths worsening, and heart failure, and about the eGFR preservation of EGFR, and not progression to ESKD. And so all these endpoints are well matched and well addressed by the single drug dapagliflozin. So use the dapagliflozin safely, bravely in all populations who are having the risk of developing heart failure, or who are having presented with heart failure with reduced ejection fraction, or you can use these drugs even in the subset of population where you want to prevent the diabetes. The studies are going on and recommendations still may going to change in upcoming years. So thank you for all for patience listening. We conclude here. Thank you so much.
Meenakshi madam.
Can't hear you. Unmute yourself, madam.
Meenakshi madam.
Madam, unmute yourself.
Dr. Meenakshi, unmute yourself.
Yeah. No. Was that hidden? Now, Dr. Virendra, please speak up. We want to hear your voice.
Yes, madam. Is it audible? Voice testing.
Yeah, now we can hear you properly.
Now it is clear. Now it's clear.
Thank you.
Okay. So, can we move forwards? Are there any questions?
There is one question. Drug of choice for ISD with pancreatitis in non-diabetic patients.
ISD with pancreatitis?
In no diabetic patient. Dr. Prakash Chimnani.
Yeah. So the pancreatitis is a chronic pancreatitis or an acute pancreatitis. That's again, we have to divide it accordingly. You have to change. Otherwise, the considerable treatment with beta blockers, nitroglycerins, can be used. And at this juncture, dapagliflozin is not recommended, and you have to treat accordingly. The pancreatitis treatment differs in chronic pancreatitis. Whether these patients are glycosilic or non-glycosilic, there's again a patient. But in those subsets of patients, valid evidence is not available. But if you want to use this patients in established cardiovascular disease for addressing the pipe defect, you can use dapagliflozin in such patients.
Okay. And the other question, diabetes, what is a good drug? Anybody of you is answering? Drug of choice in hypertension in diabetic patient. Who will be able to answer this, or should we take it after?
We'll take it afterwards, madam.
Okay.
Can you repeat your question? Drug of choice in diabetes, you can start with dapagliflozin. It has definitely shown the effect in reduction in systolic, blood pressure. At the 12-week study with the slide which I have already shown to you. So you can use, and the question remains whether the hypertension is primary hypertension or is secondary with the CKD also. If it is with the secondary also, early use of DAPA is definitely going to help such patients. Even their non-CKD population also, you can use a DAPA in such patient. But of course, if there is sympathetic overactivity, Sumit Agarwal mentioned the beta blockers and ARBs or ACE inhibitors, they are the first line of treatment. Your second line of treatment, whether you want to address, you can either use this dapagliflozin, or you have a choice of ARNI to use, or it depending upon the 2D echo and how much ejection fraction is.
Thank you, sir. I request Dr. Meenakshi Deshpande, madam, to felicitate Dr. B.B. Harshe, sir.
Yeah. Thank you, Dr. Harshe, sir. That was an excellent presentation. And from IMA Pune, we would like to felicitate you with his Uparna.
Oh, yes, thank you.
Yeah. And a bouquet. And I hope you come to IMA Pune, because whenever you are there, I hope the bouquet is seen. Because with this virtual background, yeah.
Yes. Okay.
Thank you, sir, so much. And on behalf of IMA Pune, I would really invite you to IMA anytime you wish to come.
Definitely, I'll come. No problem.
Yes.
I hope you might enjoy. The topic is a little bit difficult, but the take-home message
No,
is clear.
these are very clear. So your take-home messages were clear and you have really simplified the topic. So even, I mean, we as gynecologists also could understand much, 80% of what you spoke.
Oh, thank you. Thank you.
Thank you so much, sir. After the first two talks by diabetologists, now we have with us Dr. Amit Zinker, consultant cardiologist. The next topic is minimizing the advancement of heart disease with dyslipidemia and coronary artery disease management. The next speaker will be Dr. Amit Zinker, sir. Dr. Amit Zinker is working as a consultant cardiologist at Zinker Cardiac Care, Pune for last 12 years. Sir is also attached to institutes like Rasiklal Dhariwal Heart Care Center, NM Wadia Institute of Cardiology, Joshi Hospital, MJM Hospital. Dr. Amit Zinker, sir, has special interest in heart failure clinic, hypertension management, cardiac rehabilitation program, and preventive cardiology. Dr. Zinker manages limited invasive and non-invasive cardiology procedures independently. He has also been invited as a faculty at various local cardiology and multispecialty programs as a speaker. Also, Dr. Amit Zinker, sir, has various publications and research in various international journals. With this brief introduction, I invite Dr. Amit Zinker, sir, consultant cardiologist, to speak on minimizing the advancement of heart disease with dyslipidemia and CAD management.
Thank you, sir. I sincerely thank IMA Pune and AstraZeneca for my talk for today. Good afternoon, friends. After an extensive understanding of diabetes and role of dapagliflozin as one of the pillars in heart failure management, let's move on to one of the thorns in cardiovascular diseases, that is dyslipidemia. So let me start by sharing my slides. Okay, are my slides visible for everyone?
Yes, sir.
Okay. So let's start with understanding the challenges of cardiovascular diseases across the world and in India. Now, in India, it has been seen that cardiovascular diseases are responsible for almost 1/3 of the total deaths. And in India, the cardiovascular disease mortality is also more than 50% in less than 50 years. So nowadays, it is no longer a disease of the elderly as it was thought so previously, but now more and more younger population is getting affected with cardiovascular disease. And not only disease, but even the cardiovascular mortality has been rising very fast in this younger population. It has been shown that in comparison to the Europeans, the cardiovascular disease affects Indians almost a decade earlier. That is almost 10% of the heart attacks occur in Indians less than 40 years. And the reason for that may be the small LDL cholesterol particles in the Indian foods are more atherogenic. If you look at the inter-heart study, which was conducted across more than 50 countries, more than few decades ago, and it was found that dyslipidemia amongst all the risk factors appeared to be the strongest contributor for acute myocardial infarction in Indians. So as a corollary, if we can take care of this dyslipidemia, probably we would be able to prevent majority of the myocardial infarctions, especially in Indians. So let's start with the case scenario. Here we have a 47-year-old male insurance agent. Probably insurance agent signifies a high-risk patient, but nowadays there is stress in all professions. So any kind of stress adds to the risk profile. However, this patient is a non-diabetic, but a smoker and a BMI of 25, borderline obesity, blood pressure of 130/70 and a pulse rate of 81. It does have a family history of diabetes in both parents, even though he is a non-diabetic by himself right now. His current lipid profile shows a LDL level of 139 milligrams per deciliter, HDL of 42, triglycerides of 160. The lipid profile for the same patient 6 months ago was a LDL cholesterol of slightly on the higher side of 143, HDL more or less similar 41, triglycerides of 172. So we understand that during 6 months of lifestyle modification and without any medications, there has not been much of a change in the lipid profile management or parameters. So coming to managing the CV event risk with dyslipidemia management. Now, it has been shown that for 1 millimole per liter reduction in LDL, that amounts to approximately 39 milligrams per deciliter reduction of LDL by a statin will reduce 21% risk of major vascular events. And this reduction is across all parameters. It will also have an reduction in any vascular death or total deaths. It will also reduce major coronary events, coronary revascularizations, as well as reduction in strokes. So just even 1 millimoles or 39 milligrams reduction of LDL by statin is going to have a significant impact on the overall risk reduction. Here we can also see that the LDL reduction has a cumulative effect with ASCVD reduction, which benefits over a longer time as well. That means at year 5 versus year 10 or year 20 or year 30 or year 40, the benefits keep on increasing. It also depends on the baseline LDL cholesterol. So if the baseline LDL cholesterol is higher, then the risk reduction is also higher as compared to a lower baseline LDL cholesterol. And here we can also see that the percentage of LDL cholesterol reduction, that is from 5 to 2.5, it will be a 50% reduction. Then for a similar reduction at the lower baseline, that is 2 to 1, the risk reduction is much higher. However, if we see that if the reduction in cholesterol is less than 50%, that is 5 to 2 or 5 to 1.5, it's not that there won't be any benefit, but the benefit would be lesser as compared to 50% reduction in the LDL cholesterol. So a LDL cholesterol reduction of 1 millimoles or 39 milligrams per deciliter would probably have a 22% overall risk reduction over 5 years, which will progressively increase to up to 54% risk reduction over 40 years. Similarly, if there is a reduction of 2 millimoles per liter, this risk would further reduce to 39% over 5 years, increasing to up to 79% over 40 years. So what do the guidelines suggest? Now in 1988, when the ATP1 guideline was published, the goals for LDL cholesterol were less than 130. And at that time, there was not much of risk stratification of patients. And as years progressed, more and more data and evidence came up. And with the 2019 European Society guidelines, depending upon the risk category, the newer LDL targets can be as low as 55 in very high risk patients, in less than 70 to high risk patients, and in moderate risk patients, the target would be to reduce LDL cholesterol to less than 100. So depending upon various guidelines and various risk stratifications, the target for LDL cholesterol has changed significantly. So what is the common message in both the European and the American latest guidelines for management of dyslipidemia? First and foremost, identify LDL cholesterol as a primary target of therapy. Lower the better with proven pharmacotherapy and better lifestyle habits. All emphasizes 50% or more lowering of LDL cholesterol than the baseline, and also identify specific values of LDL cholesterol to trigger further clinical action. Each set of guidelines in addressing the primary prevention population is through estimation of the cardiovascular risk through various scoring systems. We have mainly two risk scores. One is the European score system, that is systemic coronary risk evaluation, or the American arteriosclerotic cardiovascular disease, that is the ASCVD risk score. So we can use either of these scores, which can tell us about the possible risk of coronary events in future in our particular patient. So let's see this ASCVD risk calculator. It includes age, sex, race. This is more important because this has been specifically used for the Caucasian population and may not be that valid for our Indian or South Asian population. It also uses other parameters like blood pressure, cholesterol, history of diabetes, history of smoking, whether or not on hypertension treatment or presence of a statin or an aspirin therapy. Now, for our particular patient, the current 10-year ASCVD risk comes to 6.3%, which is borderline. So 7% is the cutoff, wherein we say that if the risk is more than 7%, it's considered as elevated. If it is less than 7%, then it is not of that significance. However, as we said that based on the race, this risk is probably underestimated for the South Asian population. So to look at this caveat, the guideline suggests that if the risk decision is uncertain, we can consider measuring coronary calcium score based on CT angiography in selected adults. So this coronary calcium scoring is not required as a screening tool for all patients, but it can be used only in selected patients where we feel that the risk category would be slightly higher. And based on the coronary calcium score, if it is 0, then it would be a low risk patient. And in that scenario, no statin would be required unless there would be associated diabetes or family history of premature coronary heart disease or cigarette smoking are present. If the coronary calcium score is between 1 to 99, it would favor a statin treatment, especially after the age of 55 years. However, if the calcium score is more than 100 or more than 75th percentile, then definitely this patient should be initiated on a statin therapy. So it has been recommended for optimal risk reduction, the levels should be reduced by 50% or more from the baseline LDL cholesterol. Now we need to set a goal for more than 50% LDL cholesterol reduction. Here we can see the number of people who could achieve a reduction of LDL cholesterol. The white is a placebo where there was no reduction. The pink is no reduction or increase in LDL cholesterol. The light blue suggests reduction in 50% cholesterol, and the dark blue suggests the number of patients who had more than 50% reduction in cholesterol. And if we look at the event rates in these 4 groups, it is very clear that those patients who had more than 50% reduction in LDL cholesterol had the least event rates as compared to those who could not achieve more than 50% reduction in LDL cholesterol. Here we can also see that the number needed to treat patients to prevent one event would be lower if we look at the 50% target. So here are 2 graphs which compare LDL cholesterol for 20% reduction from baseline and LDL cholesterol for 50% reduction from baseline. So if we consider 20% reduction, the numbers needed to treat to prevent one event would be 63, whereas for 50% reduction from baseline, we would need only 26 number of patients to reduce one primary event. Hence, this also suggests that if we achieve reduction of more than 50% cholesterol in maximum patients, more and more primary events would be prevented. This is the statistical difference. In 50% reduction in cholesterol, probably only 26 patients would be needed to treat one event, whereas 63 persons would be needed to treat to prevent one event when we target the LDL cholesterol to just 20% from baseline. So depending upon the risk stratification, whether it is low risk, moderate risk, high risk, or very high risk, which is defined by the various scoring systems, where low risk is considered as a European score of less than 1%, where the treatment goal for LDL cholesterol would still be 116 milligrams per deciliter. In moderate risk category, where the score is between 1 to 5%, or in younger patients having diabetes in less than 35 years or type 2 diabetes in less than 50 years, with the diabetes duration less than 10 years and without any other risk factors, would be considered as a moderate risk patient. And in these patients, the target for LDL cholesterol would be to get below 100 milligrams. In cases of high risk patients, which are considered as a score between 5 to 10, this is a European score and not the ASCVD risk score. Markedly elevated single risk factors, in particular, if the total cholesterol is more than 310 or LDL cholesterol more than 190 or blood pressure of 180 over 110, if there is any family history without any major risk factors, family history of coronary artery disease, if there is moderate CKD with the eGFR between 30 to 59, or if there is presence of diabetes without target organ damage, and duration of more than 10 years of diabetes or additional risk factor. In this particular risk category, the LDL targets would be to reduce to less than 70 milligrams per deciliter. And lastly, for the very high risk category, which is based on clinical or imaging diagnosis of atherosclerotic cardiovascular disease, or if the score is more than 10%, or if there is family history with ASCVD or with another major risk factor, or if there is severe CKD with eGFR of less than 30, presence of diabetes and target organ damage, more than 3 major risk factors, or early onset of type 1 diabetes, which has been present for more than 20 years. So this is a very special, very high risk category where we intend to reduce the LDL cholesterol levels to as low as less than 55 milligrams per deciliter. This particular category definitely amounts to more than 50% reduction from the baseline LDL cholesterol levels. So coming back to our specific patient, this particular box is for our patient where despite lifestyle intervention, we couldn't achieve reduction of more than 50% reduction in the LDL cholesterol. Hence, consider adding a drug if uncontrolled only on lifestyle intervention. So we need to add drug as patient is uncontrolled based on lifestyle monitoring. Now, only statins are recommended to reach LDL cholesterol goals for patients. It is recommended to prescribe a high-intensity statin up to the highest tolerated dose to reach the goals set for the specific level of risk. And this has got a class 1 with level A evidence of indication. Coming to primary prevention and what is the place for rosuvastatin. Amongst all the statins, we majorly have only atorvastatin and rosuvastatin with us. So what are the basic differences between these two statins? Atorvastatin is lipophilic, whereas rosuvastatin is hydrophilic. So that would suggest the pharmacokinetic differences. Also, atorvastatin needs CYP3A4 for its metabolism, whereas rosuvastatin is non-CYP450 and with limited CYP2C9/8 would be needed for its metabolism. Hence, drug interactions would be minimal with rosuvastatin as against atorvastatin. The clearance for atorvastatin is only hepatic, whereas rosuvastatin can be cleared both hepatic and renal ways. The half-life of atorvastatin ranges from 11 to 30 hours, whereas for rosuvastatin it is 20 hours. And if you look at the effect of food on the bioavailability, food definitely affects the atorvastatin absorption. It reduces by almost 30%, 13% after food, whereas rosuvastatin does not have any effect of food on its bioavailability. For primary prevention, Jupiter was one of the largest trials which had used rosuvastatin, and it observed change in lipid parameters as well as the HRCRP levels from baseline with rosuvastatin versus placebo. It clearly documented that there was a significant drop in LDL cholesterol, more than 50% as against placebo. There was slight improvement in the HDL cholesterol. There was 17% reduction in triglyceride levels, and moreover, 37% reduction in the baseline hsCRP levels, which is an inflammatory marker suggesting higher risk of coronary artery disease. Rosuvastatin treatment also reduced the risk of cardiovascular event by 44% and mortality by 20% as compared to placebo. So here we can see that across all various parameters, including myocardial infarction, stroke, unstable angina, revascularization, or cardiovascular death, it all reduced up to 44%, and the number needed to treat was just 25 to reduce all these events by 44%. Not only that, it also reduced the cardiovascular events in CKD patients, as well as the all-cause mortality in CKD was also reduced by 44%. But all are the rosuvastatin brands the same. Here is a slightly complicated theoretical diagram which suggests that there has to be a different level for a safety as well as efficacy for a particular drug. And we need to balance a midline wherein the drug's bioavailability should be such that it should not only be efficacious, but also should be free from side effects. This is the upper specific statistical process control limit, and this is the lower limit, and this is the midline. So any ideal molecule should have its bioavailability more or less towards the midline to have best efficacy and least of side effects. So with the innovator molecule, the expected efficacy range would be much better, and reduced drug efficacy or increased side effects would be there if the generic brand has deviation to more than 20 to 25%. It was published in a journal with atorvastatin that the generic brands with atorvastatin obtained from multiple sources worldwide contained a methylated impurity which reduces its HMG coenzyme reductase inhibitory effects. A methylated atorvastatin was highly conserved in generic atorvastatin formulations, and this impurity will have no inhibitory effects on HMG enzyme activity, thus reducing its efficacy on cholesterol reduction. And the presence was widely available across the various versions of generic atorvastatin across the world, and it may also compromise the global efforts towards the effective management of lipids. So compared to innovator statins, the probability of suffering of a cardiovascular event for the generics was higher on an average of up to 31%, as was shown in this particular trial. Now, if we look at rosuvastatin also, this is the active molecule of rosuvastatin, calcium, and there can be impurities during or after production of rosuvastatin tablet, and these can impact the stability of rosuvastatin formulation as well as the overall shelf life. So it will ultimately result in lesser reductions in LDL cholesterol for the same dose of rosuvastatin in innovator brand versus the generics, and increasing the dose may probably increase the side effects as well, and at the same time compromising on the actual efficacy of the molecule. So with that, to summarize, I would summarize that dyslipidemia is a major risk factor for cardiovascular diseases, which are the #1 cause of deaths worldwide. The lower the better, that is cardiovascular event risk reduces with reduction in LDL cholesterol levels. The risk of CVD is higher in Indian patients than the Western counterparts. The guidelines recommend setting of LDL cholesterol goals for patients for primary prevention and use of statin as a first line of therapy to reach the goals set for the specific level of risk. Hence, risk stratification is very important for primary prevention as well as for secondary prevention, and depending upon the risk, the different goals can be set for LDL cholesterol, and accordingly the dosage of statins can be recommended. Rosuvastatin helps reduction in LDL cholesterol by more than 50%, as well as the risk of cardiovascular events by 44% as against placebo. And compared to innovator statins, the probability of suffering a cardiovascular event for generics was probably higher on an average of 31% in case of atorvastatin, but the same may be true with rosuvastatin as well. Thank you so much for your patient hearing. With that, I would end my talk and hand over the platform again to the IMA speakers. Thank you so much.
Thank you, Dr. Zinker, sir. Meenakshi, madam, your comments.
No, there are a few questions. I think I would request all the faculties to go to the prescription point of view. If a doctor wants to write a prescription, I think there are the questions pertaining to that in the question box. What is the ideal drug which you would like to, drug of choice from your side for a dyslipidemia with hypertension with diabetes? So Zinker sir or whoever can answer this question would be better.
So, as we saw the differing pharmacokinetics between atorvastatin and rosuvastatin, rosuvastatin definitely carries a slightly higher age as far as the side effect profile or efficacy is concerned. So hence my first prescription for primary prevention would definitely rosuvastatin. The issue with diabetes or hypertension would be just differing risk stratification, and the targets for LDL reduction would be different depending upon the risk. Whereas the drug of choice would still be rosuvastatin at moderate to high intensity.
Okay, and what will be the dosage, sir, at the beginning?
It has to be moderate intensity minimum, that is 20 milligrams of rosuvastatin. And if it is a very high risk category, then probably at 40 milligrams of rosuvastatin.
Okay, fine.
There is another question. Treatment of myopathy because of statins.
It has been found that vitamin D deficiency was associated with higher risk of side effects with statins. So if someone is vitamin D deficient, then they should be supplemented with vitamin D. Secondly, maybe you can reduce the dosage of rosuvastatin that is being currently prescribed to maybe half the present dose. And despite that, if the myopathy doesn't settle, maybe we need to stop rosuvastatin completely for a few days. And once the myopathy settles down, maybe we can try restarting it at a much lower dose and see the response of the statin therapy.
Thank you so much, sir.
Yeah. If anybody else is having any questions, then they can put them in the chat box. We will take them at the end of the session.
May I request our President, Dr. Meenakshi Deshpande, Madam, to felicitate our speaker, Dr. Amit Zinker, sir. I also request Dr. Amit Zinker, sir, to kindly accept the felicitation on behalf of IMA Pune.
Thank you.
Thank you, Amit Zinker, sir. It was a wonderful presentation. I am listening to it very carefully, and even we are finding it very nice. And this is a Uparna, if you can see, from IMA Pune for you.
Yes, definitely. Thank you.
Thank you, sir. And we request you to come to IMA Pune whenever it's possible. A bouquet for you.
Thank you.
Yeah.
So now we proceed to the next talk. We have with us eminent cardiologist, Dr. Hemant Kokne, sir. Dr. Hemant Kokne, sir, is a assistant professor in cardiology at BJMC, GMC and Sassoon Hospital, Pune. He has done his DM cardiology from Lokmanya Tilak Municipal Medical College and General Hospital, Sion, Mumbai, one of the highest volume and renowned cardiology center in India. Sir is expertise in interventional as well as non-invasive cardiology. He specializes in coronary angioplasties with stent implantations, IV US guided angioplasties, rotablation, chronic total occlusions, and bifurcation stenting. Structural heart disease, BMV, permanent pacemaker implantation, ICD implantation, ASD. In non-invasive cardiology, sir is expert in echo, 2D echo, 3D echo, TEE, stress test, etc. With this brief introduction, I request Dr. Hemant Kokne, sir, to speak a few words on why early intensification with DAPA is in HFrEF is critical. A complete story with patient profile. Over to Dr. Kokne, sir.
Thank you very much, IMA, for the opportunity. I'll be sharing the screen. Yeah, is the screen visible?
Yes, doctor, please go ahead.
Okay. Okay, myself, Dr. Hemant. I'm assistant professor in cardiology at BJ Medical Pune. I deal mainly with electrophysiologic and heart failure cases. Now, the topic today is why is early intensification with dapagliflozin in Hfref critical? A complete story with patient profile. So basically, what the topic means is dapagliflozin, when to initiate and why it is important to initiate it early in a patient with heart failure with reduced ejection fraction. We'll be backing up with data and study. The backbone study of this particular talk is DAPA-HF, which conclusively established the role of dapagliflozin in heart failure, dapagliflozin being an anti-diabetic. The study which was conducted at BJ Medical and Sassoon Hospital, and I being the principal investigator for the same. So I'll just start with the introduction, basically. So what is this heart failure with reduced ejection fraction? It's okay. So we know that a patient of heart failure is always at very high risk of death and hospitalization, either death or hospitalization. almost 9 out of 10 patients are symptomatic with current standard of standard treatment that they are receiving. 1/3 of the patients are high risk hospitalization or severe death. Also, those patients who appear stable, we'd never know that when they can face a tragedy of sudden cardiac death or something like that. Also, each episode of hospitalization that patient has for heart failure, it increases the risk of mortality further. The numbers, if you want to know, they are basically after first heart failure, it is expected, I mean, it is predicted that patient will survive for only 2.6 years. And consecutively, the duration goes down and down. So much that if patient has 4 episodes of hospitalization for heart failure, his mean survival is hardly 1.5 years. Such is the impact and such is a dread of this, what we commonly call as DCMP, direct cardiomyopathy. That is in technical terms, what we call is heart failure with reduced ejection fraction, or DCMP, or your plain heart failure, CCF, what earlier we used to call. So these are the terminologies related to this talk. So what has happened is in recent times, last few years, there are multiple newer therapies which are groundbreaking and nearly very good landmark studies have been taken worldwide, and they have come up with really some good molecules which are prolonging the life of the patient and trying to improve the quality of life. The main problem with these heart failure patients is the quality of life is quite compromised in view of dyspnea, the limitation of mobility, and patients being sometimes bedridden, the cost of therapy, and loss of employment. These are the issues that are faced by the patients of heart failure. So these new therapies are making the patients work, walk, move around, take their own self-care. So that's a big asset that we can say. But still, what is the residual risk? And it still persists. So what we can do to reduce that risk further? Okay, so we'll just revise some studies which have been groundbreaking in this particular aspect. So this was the first study, Paradigm HF. This was the study which was a head-to-head comparison between enalapril and LCZ696, which we know now is sacubitril valsartan, and it was shown that ARNI, a 20% benefit on and above enalapril use was found in terms of mortality, morbidity, and history for hospitalization for heart failure. It was a very significant study, but still there is some, as you can see, there is some residual risk still remaining. This ARNI was the groundbreaking therapy which superseded the use of ACE inhibitors. Then came dapagliflozin. So role of dapagliflozin when used early. Now we are speaking this talk is pertaining we are not underlining the importance of dapagliflozin in heart failure with reduced ejection fraction. We are not dealing about ARNI. We are not dealing about any other anti-failure drugs individually. But what we are trying to give is a holistic approach of starting the treatment, the doses, and practical aspects that we are going to deal. Okay, so just in brief about the studies. Now I have told you about Paradigm HF study. Now this is the DAPA HF study. It was a study of 4,744 patients, 1:1 double-blind. DAPA 10 mg was compared with placebo. 2,373 patients were compared head-to-head. Now, interesting fact is at that time dapagliflozin was an anti-diabetic agent. This study had 45% diabetic patients and 55% non-diabetic patients. So irrespective of diabetic status of the patient, there was a 26% relative risk reduction with a significant p-value and numbers needed to treat of only 21. So this is a very significant findings that they got. The CV death was reduced 18% and hospitalization for heart failure was dramatic. Now this is an important part of component of this result, because there is a 30% risk in 30% reduction in relative risk for hospitalization or for heart failure, which means this much cost of the patient is going to, we are saving this much drain of finances of the patient with each admission for hospitalization for heart failure. So this is an important finding. Now there has been a consistent benefit across a broad spectrum, whether the patient is diabetic, whether the patient is non-diabetic, baseline EF, whatever it is, 30%, 20%, 25%, levels of pro-BNP, diuretic use, background therapy, EGFR. It has shown to be 20-25%, 29% beneficial across all the spectrum. Plus, it was very well tolerated. It had very less adverse events, and there are no major events of hypoglycemia in a non-diabetic patient also, or DKA patient also. It is important because we are using a diabetic drug, anti-diabetic drug, in a patient who is not diabetic. Okay. So with this, pertaining to this talk, what is important is the benefit of this drug was seen as early as day 28, okay, with a significant p-value. So it was seen that at worsening of heart failure was the positive effect of this drug was seen as early as day 28. So that's why we are speaking about this drug being a potential candidate for starting as a early therapy. Okay, so is it a single drug? No, you can add it, and the benefit that it is going to give, it will be over and above the ACE inhibitors, ARBs, and beta blockers. Now we all know heart failure, acute heart failure, decompensated heart failure, Hfref. The default treatment is ACE inhibitors, ARBs, beta blockers. So dapagliflozin will give clinical benefits over and above the use of ACE inhibitor, ARB, and beta blocker. If a patient's already on ACE inhibitor and ARB and beta blocker, there is almost a 34% relative risk reduction versus placebo. So this is an important thing, that it is not that the patient will get benefited if he's not on ACE inhibitor, ARB, and is on dapagliflozin. Over and above, the benefit is being passed on to the patient. So dapagliflozin plus ACE inhibitor plus beta blocker, and placebo plus ACE inhibitor plus beta blocker. So there is it showed 10.8%, and this showed 6.5% event rate. So there is a 40% reduction in event rate when we match these two arms with ACE inhibitor and beta blocker. So this is a 40% benefit, which is over and above the use of these two standard drug therapy. So it has now been conclusively proven. Okay. So these are the effects of dapagliflozin on CV death or worsening heart failure. So all the subgroups almost have been covered with this drug. So patient's diabetic status, patient's age, systolic BP, BMI, heart failure, whether it's ischemic etiology or non-ischemic etiology, duration, diuretic therapy. Also, if a patient is background heart failure therapy, then yes, a bit of sacubitril valsartan is giving a bit of non-correlation, but baseline pro-BNP, reduced EF, renal function, these all are showing that it is consistent. The effect is, the effect of the drug is consistent. Also, composite of ventricular arrhythmia, that is resuscitated cardiac arrest or sudden death. These are the life-threatening events that we are speaking of. In that particular events, there is a 20% relative risk reduction when compared to placebo. So we can safely say that the sudden causes of sudden cardiac death, dapagliflozin is giving 21% more benefit over the standard therapy. Also, significantly more patients receiving dapagliflozin had improvement, and few had deterioration in heart failure symptoms at 8 months. So 18% more likely to have symptom benefit. Now, this is what I was telling, the quality of life. So this is a scale that is KCCQ, which is used for analyzing the quality of life for the patient. So it was 18% more likely to have symptom benefit. Patient will have less symptoms. Also, as we can see, it's a point scale. So dapagliflozin was much better than placebo when it was compared with the quality of life, which is symptoms. Now, there was other arm. This is DAPA HF arm. There was other arm of the study, which is DAPA CKD. In that arm also, there was 39% reduction, relative risk reduction in composite of sustained EGFR decline, end-stage kidney disease, renal CV death, and 36% with diabetes patient, and 50% reduction in non-diabetic patients. This particular arm of dapagliflozin was stopped early because it was showing overwhelming efficacy. The drug was apparently so effective that the numbers needed was achieved very early, and it was stopped prematurely, and drug was declared to be quite effective. There was a 31% relative risk reduction in all-cause mortality in this particular arm. so DAPA-CKD. So now we are concerned with treatment of a patient who is first 100 days post heart failure discharge. So the newer guidelines will come to later, but it is always beneficial to start this particular drug, SGLT2 inhibitor, as early as possible, to an extent that we can even think of starting it in a hospital when patient is still admitted. So within days to weeks, if it is started, we have data, then we have favorable BP and kidney profiles. Then the patient's GDMT, that is guideline directed medical therapy, is initiated, at least initiated early. Then we have a favorable glycemic safety profile in a diabetic patient as well. Also, it is a synergistic with MRA, that is mineralocorticoid receptor antagonist and RNA, and it is well tolerated and safe. So this is a candidate, that's dapagliflozin is a very good candidate for early initiation, or in fact in hospital initiation. So basically, if there are 87% of the patients who are admitted for heart failure with reduced ejection fraction, 87% would be dapagliflozin candidates. Such is a coverage of this or in the coverage of indication for this particular drug. So basically what they have done is reduce ejection fraction less than 40%. This study was based on is a registry based study, and it shows that eligibility for dapagliflozin is almost as high as 87% in a patient who is admitted with Hfref. So we don't have any dearth of patients in this particular aspect. So initiation benefits of dapagliflozin initiation at discharge on post-discharge mortality. This particular thing, that is medical beneficiaries data, GWTG heart failure, who had started on dapagliflozin. So there is a 5% absolute risk reduction with dapagliflozin implementation. So this is like simulated benefits of dapagliflozin implementation on mortality. So early start will give you additional 5% of benefit. Okay. So next is, now let's go to what are the, when we consider initiation of medical therapy in Hfref. So what are the backbone? What is the backbone of this particular therapy? So day one, like patient gets admitted for heart failure. To the initial 1.5 months up to 6 weeks is considered as initial period of therapy to be started. The goal is to put the patient on all the anti-heart failure medications, which are shown to be have survival benefit, and those are who are proven drugs. So now, as you can see, day one, let's so these are 4 or 5 drugs we need to know. One is ARNI, other is beta blocker, ARNI instead of ACE inhibitor. Beta blocker has to be there. Mineralocorticoid receptor antagonist, that is aldactone, and dapagliflozin, that is SGLT2 inhibitor. So day 1 to 4, we can consider these all drugs. If patient is on ARNI, we have to continue it as it was. Day 14, we can consider looking at the RFT, electrolytes, potassium level, whether we can titrate it to upper doses if it is tolerated. So whatever maximum tolerated doses, day 14, beyond day 14, we can titrate and give as it is tolerated. The main aspect here is hypotension and derangement of electrolytes, that is potassium. Beta blockers, we have to start and we have to titrate as per toleration, as per tolerated. Same way with, if patient is already on mineralocorticoid receptor antagonist, we need to continue it. And at day 14, we can titrate it to upper side as per patient's tolerability. If patient is on SGLT2 inhibitor, just continue the drug. There is no need of titration and nothing else. So low starting, so the benefits, so basically what we need to know is we have to focus on complete set of quadruple medical therapies, and patients should receive all the 4 drugs, okay, and in appropriate doses. We'll come to it in a while. So now what should be the sequence? I mean, do we add therapies to present HFrF, or we just start all the drugs at a dose and then go on increasing? We'll just discuss it. Now, this is a slide. Basically, we have, when we combine foundational therapies, can extend the lives of patients with heart failure by 6 years. So comprehensive therapy and conventional therapy. Now by conventional therapy, I mean beta blockers, ACE inhibitors. And comprehensive therapy is what we have discussed, the 4 aspects. So it is increasing increasing the life of the patient by almost 6 years. So comprehensive includes ARNI, beta blocker, MRA, and SGLT2. We'll be focusing on these 4 drugs. At least after the talk, if you are able to, if you are able to remember that these are the 4 drugs which have to be given to a heart failure with reduced ejection fraction, I think the purpose of this talk is solved. So these are the 4 drugs you just get in mind. If a patient is having LV dysfunction and a patient of heart failure, your target should be to put the patient on these 4 drugs versus conventional, which is ACE inhibitor, ARB, and beta blocker, which many of the patients are on. NVAS, ATEN, enalapril, atenolol, enalapril, metoprolol. Patient is always on those drugs, and there is no diuretic here. There is no Lasix. There is no torsemide or these drugs here. Here we are talking about the drugs which are going to prolong the life of the patients. Okay. Now we'll just go see what happens normally in ICU if a patient gets admitted with heart failure with reduced ejection fraction. Step 1, we just add ACE inhibitor, ARB. Then we add a beta blocker. Then we add a mineralocorticoid receptor antagonist. Then we think of adding ARNI. Then we get all electrolytes and everything done. Then we add a patient on ARNI. Then we think that yes, dapagliflozin, we have studies, we have this, we have that. Patient is diabetic, non-diabetic, whatever, will add as SGLT2 inhibitor. So this goes on stepwise. And believe me, everyone has experienced it. It takes at least 6 months for a patient to be put on all these drugs. Okay, because we go sequentially. So this is what I want to convey, that we need not go sequentially. What happens in this sequence is prescribers, what they do is we give a drug, we titrate it to next particular drug, we see the side effects, we see blood pressure. So the limitations are, there is a delay, there is a lot of time lost. Maybe patient might get again a heart failure episode in between these 6 months. Okay, so there is a delay, so that time is lost. Second thing, and as we know, each heart failure episode hospitalization is deteriorating for the patient. So we need to avoid those episodes. Also, it is assumed that also we say that we have to go with the trial doses. That is, we have to go enalapril 10 mg BD or beta blocker 50 mg BD or something like that. So we go after that, say achieving perfection for that particular drugs. So this is a drawback. Okay, so now what they're coming up is, what is a new expert proposal for a sequencing of these particular drugs is we start the drugs early. So what are the steps given by them? First, take a beta blocker and take a SGLT2 inhibitor. Take metoprolol or bisoprolol in a dose. You can titrate it later on. Just start 2.5 mg, 5 mg, whatever is suitable depending on the heart rate, blood pressure, lung status. Take a dapagliflozin and start. Okay. Then within 1 to 2 weeks of step 1, add an ARNI. Okay. So this is the first time we are adding a ACE inhibitor, ARNI we are adding. And then within 1 to 2 weeks, add a mineralocorticoid receptor antagonist. So this all is completed within a month. This is the most important slide of this particular talk. We need to do this. We need to follow this. So ultimately, within a month, patient is getting benefit from all the major anti-heart failure medications that that world has. I mean, that what is available in the for him. Okay, so all therapies are started within 4 weeks. So this is the sequence that needs to be followed, and not that first add a enalapril, then wait, then add a bisoprolol, then wait, go higher on the doses, then dapagliflozin. This is, if we do follow this, this is going to give maximum benefit to the patients. So sequencing also, this is the slide which is again stressing the same points, that what happens is we start with ACE inhibitor, then 2 to 4 weeks titrate, 2 to 4 weeks more titrate, 2 to 4 weeks more titrate. Same thing happens with the beta blocker, mineralocorticoid receptor antagonist, ARNI and SGLT2. So it takes 28 to 56 weeks till the patient is fully on all the doses. I mean, all the drugs with their appropriate doses. So just cut time on that. Just prepone or everything. Okay. So patient profiling for heart failure, when we tailor a medical therapy, these are the 4 aspects we need to look when we profile a patient of heart failure. Important is heart rate. So less than 60, 60 to 70, more than 70. So sorry. Okay. Blood pressure 90/60, more than 90/60, and more than 140/90. With or without heart, without lung congestion, with or without atrial fibrillation, with renal impairment, that is CKD, and without renal impairment. So 2021 consensus statement recommends that we start SGLT2 inhibitors as a component of foundational therapy for all HF-REF patient phenotypes. So all the phenotypes, this is a very good slide which includes everything, that is heart rate, blood pressure, renal status, and atrial fibrillation status. So SGLT2 inhibitor is a component of all the subsets, all the combinations. I mean, you just combine all these things: heart rate, blood pressure, AF, and CKD status. So SGLT2 inhibitor is a component of all this, and this has come in 2021 ESC guidelines. Okay, now let's go to guidelines. We all believe in guidelines, we all follow the guidelines, and what we need to know is what are the latest guidelines for this particular dapagliflozin. So a strong guideline recommendation is from ESC 2021 heart failure guidelines. Dapagliflozin is recommended as one of the cornerstone therapies for heart failure with reduced ejection fraction. So ACE inhibitor, beta blocker, MRA, dapagliflozin, and a loop diuretic for fluid retention. It is a class 1 indication for management of HFrF. So this is a medical therapy which a patient should be on with appropriate doses with well tolerability. This is the target. Now, additional things is if EF is less than 35% with QRS is normal, then we can consider ICD. If EF is less than 35% and the QRS is wide, we can consider cardiac resynchronization therapy with a defibrillator. And if it is not, then we can go with class 2 recommendation drugs. I think we will not go into details, but this is what is important in medical for medical therapy. Now, ACC, Americans also say this, similar thing in a bit different way. They say that use ARNI, beta blocker, diuretic as needed. Okay, and then keep on adding these drugs. I mean, MRA is given, SGLT2 inhibitor, dapagliflozin, diuretics. They have also said that hydralazine isosorbate dinitrate and ivabradine can be used for, depending on the hydralazine is for black patients, African-American race. Ivabradine can be used for patients who have baseline heart rate which is more than 70. So they also say that ARNI, beta blocker, MRA, SGLT2 are the first line medications for all patients with HFrF. This is a very important line, that we have to take all these 4 drugs and use it and start using as early as possible in our HFrF patient. So summarizing the talk, I'll say that the 5-year mortality of a patient who is diagnosed with HFrF is about 50%. So half of the patients you are seeing today will be no more by 5 years. So that's the importance of acting, and that acting fast, acting early, and giving treatment aggressively. I mean, giving the tablets, but very aggressively, and adjusting the doses aggressively. So class 1 recommended therapies is beta blocker, MRA, dapagliflozin. Just remember all the 4 drugs and remember all the 4 doses and start the patient on these drugs as early as possible and as aggressively as possible. Dapagliflozin is the first and only SGLT2 inhibitor which is demonstrated a reduction in CV death, all-cause death, and hospitalization in patient with HFrF with or without diabetes. So it is a first drug that was found to be effective. So that's it for today. And yeah, thank you very much.
Thank you, sir.
Yeah.
There are no questions. Meenakshi madam, comments please.
Yeah, Dr. Kokane, I think it was a most comprehensive talk, I think, which you have given, and which many take-home messages, especially your last 3 or 4 slides were very, very useful. And I think what point you are focusing, that we have to start all the 4 medicines, even there at the right time and at the right dosing, then patients can be saved of that 50% of mortality which you are claiming, that patients after 5 years are no more of this heart attacks or cardiac failure patients. That is a revelation for us and an eye-opener lecture for all of us. So thank you, sir, for a very nice lecture and a good understanding of the topic which you have given to us. So thank you.
Thank you, ma'am.
Thank you, Dr. Hemant Kokne, sir. I request our President Meenakshi Deshpande, madam, to felicitate Dr. Hemant Kokne, sir.
Yeah. Sir, this is a Uparna for you.
Thank you.
I'm just putting it in the camera. Yeah. We really wish you to come to IMA Pune. You are there in BJ Medical, I think.
Yes, ma'am. Yes, ma'am.
So you can really visit us anytime. And
Yes.
this is a bouquet for you. Thank you, sir, for an excellent talk and a very good take-home messages which you have given us. Thank you, sir.
Thank you, ma'am. Thank you very much.
With this, we proceed to the next talk. It is a case study on mitigating ischemic risk post complex PCI. The next speaker is Dr. Rajesh Wagh. So I welcome interventional cardiologist, eminent cardiologist, Dr. Rajesh Wagh. He is working as an associate professor in Department of Cardiology, Bharati Vidyapith Medical College, Pune, since last 6 to 7 years. I'll briefly introduce him. He has done his MBBS from Mymar Medical College, Latur, and he's completed his MD Medicine from BJ GMC Pune in 2010. He has completed his DM Cardiology from Grand Medical College and JJ Hospital, Mumbai. He is also attached with as a panel consultant at Pune Hospital, Ruby Hospital, Global Hospital, and Sahyadri Hospital. Dr. Rajesh Wagh has his practice his own clinic as Wagh Heart Care and Specialty Clinic at Katras, Ambegam. So with this short and brief introduction, I request Dr. Rajesh Wagh, eminent interventional cardiologist, to talk on case study on mitigating ischemic risk post complex PCI. Over to you, sir.
Am I audible to everybody?
Yes, sir. Clear.
Thank you, sir, for this kind introduction of mine.
Please share your screen, Dr. Rajesh.
Yeah, I will share my screen.
Yes. Yeah, it is shared.
Yeah, I will just switch into PPT mode. Okay. Now, is it visible to everybody, my presentation?
Yes.
Okay. So thanks, sir, for giving opportunity at this platform of IMA to present such a wonderful talk. Now, I am going to present a case study on mitigating ischemic risk post-complex PCI. So this is not a general normal angioplasty which is done for type A lesion. This is a complex angioplasty which will be requiring multiple stents, bifurcation, or many things. Okay. So first, we are going to deal with this, a 55-year-old female hypertensive diabetic patient. So she has multiple risk factors. She is hypertensive, diabetic. Her GFR is also quite on the lower side. And she has effort angina, which recently worsened into rest angina. So her perfusion thallium scan was done, and that was showing her LV ejection fraction was preserved, but had multiple perfusion defects, which was seen in anterior and inferolateral walls. So her angiography was done, that was showing completely diffusely calcified vessels with proximal left LAD, and chronic total occlusion of LAD was seen. Subtotal occlusion of diagonal was seen, and left circumflex artery was also narrowed from the ostium. Okay, so this is his LAD, which was filling through collaterals. It's very difficult because this is a right coronary artery shoot, which is showing that LAD is filling from collaterals from the RCA. So that much disease it was there. So definitely the good thing was that she had collaterals and she had never had MI. So her ejection fraction was per 45 to 50% EF was preserved. So her team deemed surgery, but was not recommended because she has multiple comorbidities. She had COPD, so it was not, she was not fit for surgery. So it was the decision was made to do angioplasty for this patient. So again, angioplasty was done with culotte technique and T protrusion. These are some modifications which are done for bifurcation. And according to that final, despite initial good result, the distal LED got occluded at the site of drug-eluting balloon treatment. So distally, the LED got occluded because of the balloon inflation. There was small dissection flap. And so culotte and tap technique. So this late LED occlusion was there. You can see that in the image F, you can see that LED is cut off at the distal end. So M stent was said to be delivered in the distal LED. However, it got trapped in the proximal LF main segment, and then the maze began. Finally, the left main stent got dislodged, and it became evident. So finally, somehow that stent was successfully retrieved by gooseneck technique. So finally, the stent delivery was done at the distal end, and some extravasation was seen. You can see that some perforation was seen in E and F. So that perforation was also that lead to tamponade. So again, that tamponade again lead to finally thrombotic occlusion of left main and proximal LED. So this is again one of the complication of perforation, because once you perforate some artery, there is we have to decrease the dose of heparin, and so that lead to again thrombotic complication. So finally, somehow rescue PCI again was done with antegrade flow was restored, and covered stent was put at the site of perforation. Covered stent is a stent which has no studs. It has directly mesh, so that prevents the lateral flow of blood. So that leads to sealing of the perforation. So finally, somehow hemostasis was achieved and hemodynamic status was recovered. And finally, the tamponade was also tapped, the thrombus was also aspirated, and the leakage was also occluded, but still the distal flow in LED was slow. So what is complex PCI? Are such patients at higher ischemic risk? Yes. So complex PCI, what is the definition of complex PCI? So we are dealing here with complex PCI means all three coronary vessels have been stented or vessels have been treated. There are more than 3 stents which have been implanted. Then 3 lesions have been treated. The length of total stent is more than 60 millimeter. That is more than 6 centimeter of coronary you have covered. Then chronic total occlusion. That means artery was closed for last 6 months and you have opened that artery. Then you are doing the unprotected left main PCI. Then there is stent which has got stenosis and you are opening that stent, and calcified lesion. So these are very complicated angioplasties. It requires lot of hardware, lot of efforts, and with that, the chances of stent problem in future are very high in these cases. So is this patient with complex PCI higher ischemic risk? Yes. You can see that the time of events with complex PCI, the risk of events is very high in this patient. And MACE events are almost 8%, MI event is 3%, and definite stent, probable stent thrombosis is 1.2%. So if you are doing complex PCI, not only during procedure, but post-procedure also, MACE events are very high in these patients. So for such high-risk patient, which oral antiplatelet should be chosen? Okay, so we have multiple option for antiplatelet for platelet inhibition. So most commonly used now molecule is Ticagrellar, but we have other options like Clopidogrel and Prasugren. So what are advantages of this best drug Ticagrellar which is available? It reversibly interacts with P2Y12 ADP receptor. It is active without metabolism. Now this is the problem with Clopidogrel and Prasugren, because it requires activation and then only active drug is formed. So these are prodrug. Okay, and they irreversibly inhibits platelet receptor. So Ticagrellar is irreversible inhibitor. So it is not known how pharmacology or chemical class correlate to clinical efficacy or safety. So Ticagrellar and its active metabolite are approximately equipotent. So main problem with Clopidogrel and Prasugren is that they irreversibly inhibit platelet, and their it requires activation by metabolism to form a prodrug. Plus the parent drug, the long half-life active metabolite is 9 hours T half-life, but for Clopidogrel it is just 30 minutes, and for Prasugren it is 2 to 15 hours. So active metabolite half-life is very much more in Ticagrellar. So comparison of clinical outcome, you can see that CV death MI, and all-cause death are all very less with Ticagrellar. So benefit with this drug in all three parameters, that is CV death, MI, and all-cause death, are significantly improved with Ticagrellar. So protocol for Ticagrellar is that if patients had acute coronary syndrome, if there are no any contraindication, you should directly give loading dose of 2 tablets of Ticagrellar, that is 90 milligram, and after that continue 90 milligram for BID. Now, the drug which has got good activity like Ticagrellar is Prasugren. But what are problems with Prasugren? Yes, you cannot give in patients who have prior history of stroke or TI. If you need CABG, then also the offset of action requires longer duration of time for Prasugren. So it requires at least 6 days of stopping. Then only the effect of Prasugren goes off. Offset of action is very, very long. Then if weight of the patient is less than 60 kg, you cannot give it. If age of the patient is more than 75, you cannot give it. And pro-treatment with clopidogrel, again, loading dose of Prasugren is very difficult to give because chances of bleeding are very high. So there are multiple problems with Prasugren which are not there with clopidogrel, Ticagrellar. So Plato Trial. So there are 2 important landmark trials which were done with Ticagrellar. That is Plato Trial, which was published in 2009, and Efficacy 54 in 2015. And the duration of therapy was up to 12 months. And here, Efficacy 54, the duration of treatment was 12 months to 33 months. That is beyond 1 year. So CV death, MI, stroke were studied at 12 months, and Efficacy 54 was studied from 12 months to 36 months. So Plato was up to 1 year trial of double antiplatelet post event, and Efficacy was beyond 12 months. So Ticagrellar up to 1 year was recommended, and Ticagrellar 60 milligram BD beyond 1 year. So this is the most important slide of our presentation, that for any patient who had acute coronary syndrome, you have to give Ticagrellar 90 milligram BID for 1 year. And in few patients who have less risk of bleeding, in them we can continue Ticagrellar 60 milligram BID beyond 1 year up to 3 years. Okay, so you can see that Plato Trial, in this Plato Trial, that means up to 1 year, the head-to-head comparison between clopidogrel and Ticagrellar, you can see that composite of CV death, MI, or stroke were very less. P-value was significant for Ticagrellar versus clopidogrel. Again, but if we say that the risk of death was less, but if you see the bleeding risk, that was also comparably same in both the groups. So there was no increase in major bleeding risk with Ticagrellar. So even though it is a drug potent with good efficacy than clopidogrel, but it does not have increased risk of bleeding compared to clopidogrel. So stent thrombosis was significant reduction in 36%, with 36% reduction in stent thrombosis was seen. So this is very important slide, because if you are doing angioplasty and if your patient develops stent thrombosis, it is a nightmare. Suddenly patient develops chest pain, patient has to be shifted in the cath lab, and multiple problems. So if you are comparing clopidogrel versus Ticagrellar, there was a 36% reduction in stent thrombosis was seen in these patients. So ST reduction for first few hours to 30 days, 40% reduction, relative risk reduction, and beyond 30 days, 52% relative risk reduction. So this was the most important benefit which was seen with Ticagrellar over clopidogrel, that stent thrombosis risk for first 30 days was reduced, and beyond 30 days also the risk of stent thrombosis was very much reduced. So stent thrombosis was relative risk reduction was very much significant in this patient. Now we will go to our case. So our patient had CTO, and a bifurcation lesion. So it was calcified lesion, it was CTO also, and bifurcation also. So Ticagrellar showed relative risk. So what are the head-to-head comparison for 1 year? Plato Trial effects. So there was 60% relative risk reduction in major advanced cardiac events, and 70% relative risk reduction in recurrent MI. So definitely the benefit of Ticagrellar increase with increasing duration of therapy, with no difference in major bleeding was found in patient with Ticagrellar than those treated with clopidogrel. So Now our patient has renal impairment also. So is Ticagrellar suitable for this patient? Yes. In Plato renal subset study, that is in Plato patient who had CKD, it can be seen that patients with CKD in Ticagrellar group saw a reduction in ischemic events without an increased risk of bleeding events at 1 year. So the benefit of ischemic events were not only reduced, but bleeding risk was also not much increased in patient with renal dysfunction. So again, you can see that in patient with history of MI, patient with renal dysfunction, they have very high risk of major adverse cardiac event, because per se renal dysfunction is also atherosclerotic condition. So they have high chances of recurrent MI. So you should not deny these patients a good drug like Ticagrellar so as to reduce the ischemic events. Again, treatment with Ticagrellar as compared to clopidogrel, it is Swed Heart Renal Dysfunction Registry. You can see that this is a real world study between Ticagrellar and clopidogrel. You can see that independent of EGFR, there was a separate reduction in ischemic events and lower risk of death, MI or stroke without increasing risk of bleeding. Again, you can see that the Ticagrellar had a very better doing than clopidogrel. So if patient has renal dysfunction, then also you should give Ticagrellar. So back to our case. So patient was given a loading dose of original Ticagrellar 180 mg with aspirin. Post PCI patient was continued for 90 mg BD along with aspirin, along with high intensity rosuvastatin. Definitely, this is a typical high patient need high intensity statin because she has multiple atherosclerotic lesions and 100% lesions in LAD, LCX, and RCA. So OM. So you have to give high dose statin for this patient. So patient continued Ticagrellar plus aspirin for 1 year without any complication. So till now we have learned that Ticagrellar is very much better than clopidogrel up to 1 year of post-plasty or post-acute coronary syndrome. Even she had renal dysfunction, Ticagrellar is very much better than clopidogrel in this our subset. Now, what should be done to our patient beyond 12 months? Now, this will be answered in our subsequent slides. So, patient had multiple risk factor and complex procedure, the ischemic risk beyond the first 12 months. Now, what are the ischemic risk beyond 12 months? So, then comes the Efficacy 54 trial. Now, in this trial, it was proven that in high-risk MI patient, Ticagrellar 60 mg BED significantly reduced the major CV events without much significant increased risk of bleeding. So this is our second trial, that is Efficacy 54. Now, Efficacy 54, 14% reduction in irreversible harm. So definitely continuing Ticagrellar 60 mg beyond 1 year has definitely reduced risk of CV death, MI, stroke, IC bleed, and fatal bleeding. So my patient with more than 2 risk factors get the greatest benefit from Ticagrellar 60 mg BID. Now, presence of more than 2 risk factors increases and prolongs the ischemic risk significantly. Now, what are those risk factors? If patient has renal impairment, if patient has multiple vessel disease, if patient has prior MI, if diabetes, if peripheral artery disease, age more than 65 years, if any of above 2 conditions are there in your patient and patient had MI, then you should continue Ticagrellar beyond 12 months up to 3 years, 60 mg BID, so that the patient get a benefit of 34% reduction in relative risk reduction in CV mortality and 21% relative risk reduction in CV death, MI, or stroke. So treatment with DAPT, who, when, and why? So patients with prior MI are at higher risk of thrombotic event, multivessel disease, multiple prior MI, diabetes, more than 65 years old, chronic renal dysfunction with very not increased risk of bleeding, like they have no bleeding disorders, no prior intracranial hemorrhage, they are not on anticoagulation, no any active pathological bleeding, there is no liver problem. This should also be seen in those patients. Then only these patients should be given DAPT beyond 1 year or up to 3 years. Okay, so treatment with DAPT beyond 12 months. Again, change without interruption to 60 mg after initial 1 year of 90 mg. Patient tolerance. Patients who have tolerated and adhered to the first 1 year of therapy with risk of ischemic events, risk of bleeding, no recent bleeding, no contraindication, you should continue them with Ticagrellar 60 milligram beyond 1 year. Why we are giving this? To reduce further atherothrombotic events like CV death, new spontaneous MI, including estilation MI, ischemic stroke, including disabling events. So what are the guidelines recommendations? So these are ESC and ACCHA guidelines for duration of DAPT in ACS. So in general, if patient has no increased risk of bleeding, definitely class 1 indication for 1 year Ticagrellar preferred over clopidogrel for 1 year. And if still patient has less risk of bleeding, continue beyond 12 months to 3 years, Ticagrellar preferred over clopidogrel. Now, if patient has high risk of bleeding, it's better to give Ticagrellar over clopidogrel or clopidogrel for first 6 months, and after that only single antiplatelet agent should be given. So irrespective of final revascularization strategy, means if patient has MI and they are not opting for angiography also, or if they are going for PCI, or if they are going for CABG, by default DAPT duration in ACS patient is up to 12 months, but up to 6 months duration therapy should be considered in high bleeding risk, whereas 12-month therapy should be considered in ACS patients who have tolerated DAPT without bleeding complication. Now choosing between Ticagrellar bands. Now this again happens with all drugs which come in the market. It also happened with clopidogrel, and it may also happen with Ticagrellar also. Can generics be considered equivalent to the Innovator? So no. Yes, definitely original molecule which has been tested in multiple trials should only be relied upon rather than generic molecules, because there are multiple problems with it. First is it may lead to decreased viability. So decreased viability may lead to decreased platelet inhibition, and if platelets are not inhibited, it may lead to recurrent ischemic events. Again, if viability is increased, it may lead to increased platelet inhibition, and it may lead to increased risk of bleeding. So Ticagrellar has 6 chiral centers, which means 64 possible stereoisomers can be there, which may come in market with generic drugs. So generic brand should be checked for isomeric purity. So there are multiple brands, A, B, C, D, Falana, multiple can be there. The impact of efficacy and safety is very important, because that is directly related to problems with the stent or increased risk of bleeding. So there has been trials with generic Ticagrellar, and it can be seen that the incidence of stent thrombosis increased 2-fold in some patients with that. This also happened with clopidogrel also, so this may happen with this drug also. So again, with generic clopidogrel, it was seen that bleeding risk, hemorrhagic risk was also increased by 26%. So you should always consider Innovator brand. That is because that is the molecule which is pure in chirically, and it has been studied in over more than 90 countries, approved, and 10 years experience with Plato, Phage, Atlantic, Swedheart, Treat, etc., with almost 1 lakh patients with randomized controlled trials. So you should definitely rely on the Innovator brand, that is Brilanta, which is Ticagrellar. So complex PCI patients. So final, what is our take home message? Complex PCI patients or patients with multiple risk factors are at higher risk for prolonged ischemic events. Ticagrellar is only P2 vital inhibitor which reduces CV mortality significantly and is indicated to provide a 48-month protection post ACS. So generic equivalence may differ in efficacy and safety from the Innovator Ticagrellar. Thank you.
Thank you, Dr. Rajesh.
I hope everybody was audible till my full presentation.
Yes, throughout.
Okay.
Everybody was very actively listening to your talk, sir.
Yes. And there was no technical error also from my side. That was most relief for me.
Are there any questions in the chat box? Just see, Dr. Virendra.
No, madam. There are no new questions.
Oh, so that means this was a very good talk. If there are no questions, means all the
no doubt.
I know all the what you can say questions in the minds of the delegates were answered.
Thank you.
Yeah. So
I request our president, Dr. Meenakshi Deshpande, madam, to felicitate Dr. Rajesh Wagh.
Yeah. Thank you, Dr. Wagh. This is
Thank
our
you, madam.
Uparna
Thank
for
you.
you. And
Yes.
you are from Bharati Vidyapit. No?
Yes, Bharti, and I am I was studied in BJ Medical College also. The
Okay.
medicine from BJ.
So at present you are working in Bharati Vidyapit.
Yeah. Presently, I am working at Bharti Hospital.
Okay. And this is a bouquet for you. And thank you very much for your excellent talk and very assuming, all self-explained, I think, presentation. So
Thank you, madam, for giving me opportunity to talk at that level of Indian IMA. Thank you, Pune. Thank you.
Dr. Rajeshwar, you are most welcome to be a part of IMA Pune, along with your better half.
Yes, thank you. Thank you.
With this, we proceed to the last talk of today's cardiac pharmacotherapy webinar. The last talk will be given by Dr. Yogesh Kadam sir. The topic is Glimmer of Hope for CKD patients with Dapagliflozin. May I take this opportunity to briefly introduce Dr. Yogesh Kadam sir. Dr. Kadam sir is a MD medicine physician. He is an honorary assistant professor in medicine, BJ GMC Pune. He is also the director of Pune Diabetes Center. He is a member of Endocrine Society USA, as well as he is a certified as specialist by IDF School of Diabetes. He is a clinical investigator and co-investigator in numerous global and national clinical trials since 2004. These trials are in areas of diabetes and metabolism. With this, I request Dr. Yogesh Kadam sir to give his talk on Glimmer of Hope for CKD patients.
Good afternoon, sir.
Good afternoon, Dr. Ticagrellar, and thank you IMA and thank you Astra for this opportunity. I think I am the last person, so I'll have to be brisk and crisp about this talk. Should I start sharing my screen?
Yes, please.
I hope my screen is visible to everyone.
Yes, sir.
Yes, sir, it is visible.
Right, full screen, yes. So thank you once again, IMA, and what I'm going to take you through the next half an hour is glimmer of hope for CKD patients with dapagliflozin. This is CKD is highly prevalent, and this slide shows you the CKD prevalence across the globe. And if you see roughly 14% in North America and 12% in Latin America, Asia is about 10 to 12%. India shows about 6.76. All across, if you see about 6 to 12%, even up to 14%, is the prevalence of CKD in the world, with about 843 million people with CKD. And this is patients with CKD stage 3 to 5, which means a GFR below 60. Significant CKD issues all across the globe. And if you see, rate of diagnosis is very low. So you see the rate of diagnosis, the 60% patients, 6 out of 10 patients are not diagnosed to have CKD. Only 4 out of 10 are diagnosed. So this is a pure CKD registered registry, huge number of patients. So huge, big, more than half of the patients of CKD are not diagnosed to have CKD because the clinical suspicion is low. The confirmatory tests are not done adequately on time. So a large chunk of these patients remain undiagnosed. And if you see the awareness, this is data from the NANES study from 2015 to 2018. And if you see the stage of CKD over here, as the awareness goes up only when the GFR falls below 30. Stage 4 and stage 5 CKD, when the GFR falls below 30, this is the time when the awareness goes up to 60 and 80%. But look at that, even the GFR falling below 60, 30 to 60, only about 17% patients are aware that they have got CKD. So forget stage 1 and 2 when the GFR is 60 to 90 and more than 90. Even the GFR is between 30 and 60, only about 17% patients. That means there's a big delay. Patients are not aware and not diagnosed early in stage 2 and 3, so as to prevent them from getting aggressive treatment and progressing to stage 4 and 5. So this is really something which needs to change. We have to have a very high clinical suspicion, do the test, and then patient education that you have got into CKD and stage, at least when the GFR falls below 60. I think patient needs to be counseled, patient needs to be adequately informed that your GFR is now below 60, that's significantly low and can further progress to stage 4 and stage 5. So what typically happens is that the diagnosis is not early, awareness is poor, and therefore most of the time when the patient really reaches the nephrologist, it is a stage almost getting to late stage 4 and stage 5 CKD, when they're almost getting into dialysis in a few years. So I think we need to have a suspicion, diagnose early. If you ask me, I send my patient as soon as the GFR falls below 50 or 40 for that matter, I make it a point for my patient to see a nephrologist, so that at least it gets in his mind at least it gets in his mind that I have got significant loss of kidney function, which can deteriorate over a period of time. So I need to take care, and I need to control my risk factors, what I'll be discussing in the latter part. Use a SGLT2 inhibitor like dapagliflozin to prevent the progression of kidney disease from stage 3 to stage 4 and stage 5. But it's not just kidney disease. When you have CKD, it's not that the CKD is going to progress from stage 1 to 2 to 3 to 4 and 5. Cardiovascular disease also significantly picks up when you get into no CKD to stage 3 CKD below 60 GFR and stage 5 CKD below 15 GFR. Your atherosclerotic cardiovascular disease goes up. Now, this is well known. We all know that patients of CKD would have a very high risk of cardiovascular disease, atherosclerotic cardiovascular disease, and therefore, we all do adequate cardiovascular protective strategies in these patients. What we fail to understand is that even the non-atherosclerotic cardiovascular disease picks up significantly in stage 3, in stage 4 and 5. Stage 3, 4, 5 onwards. So even the non-atherosclerotic diseases like LVH, heart failure, arrhythmias, SCD, valve calcification, emerging stroke. So even the non-atherosclerotic disease. We all know coronary artery disease, cerebrovascular disease, peripheral artery disease picks up as the stage of CKD goes on progressing. Also now what has come to light is that we need to also be aware even the non-atherosclerotic cardiovascular disease is significantly high when the CKD progresses from stage 3 to stage 5. And if you see on the right hand side, no CKD, stage 1 to 2, 3 and 4 to 5 CKD. The purple bar is systolic plus minus diastolic heart failure. The next one, the dark blue is systolic heart failure. The light blue is unspecified, and the brown is all heart failure. Every stage of CKD, all the heart failures, systolic or diastolic or both, or unspecified or overall, goes on increasing. So heart failure is a very big risk. So the filter, which is the kidney, and the pump, which is the heart, both fail simultaneously in a significant number of patients. We know the cardiorenal axis is a very strong axis. Dysfunction of one organ, either the pump or the filter, adversely affects the other organ also. The large number of these patients, as they progress to CKD, from pump to no CKD to stage 3 and 4, 5 CKD, there's a significant increase in heart failure of all types, systolic, diastolic, both systolic, diastolic, heart failure significantly goes up. So we need to keep this in mind, and we have to have strategies to address even this heart failure risk, not just the atherosclerotic cardiovascular risk, also the heart failure risk needs to be mitigated with adequate therapies like dapagliflozin in these patients. And this is again very important. What we are going through is the burden of CKD and the implications of CKD for the patients. Because here, if you see on the left side panel of this slide, the leading causes of death in CKD, as you again going on from stage 3 to stage 3A to stage 3B. This is stage 2, stage 3A, and stage 3B. You see the non-CV mortality, the cardiovascular mortality. The progression of CKD is actually very, very low. But look at the non-CV and the CV mortality goes up significantly as the GFR goes on falling. And the non-cardiovascular cause includes cancer infection. CV death is most likely because of coronary artery disease. Again, if you see, this is again a very good classification of CKD depending on the GFR and depending on the albuminuria. We need to do both these investigations in our patients of diabetes to see what group they fall in. And if you see, even in the green area, even in the green zone, which is considered early CKD, you see that the CV risk is increased more than 1. But when you go to the moderate risk and severe risk patients, you look at that risk, the cardiovascular risk, CV mortality, not the cardiovascular risk, but CV mortality goes on jumping from 2, 3, and more than 5 and 8 over here towards the end. So as the albuminuria increases, as the GFR starts falling, the cardiovascular risk mortality just goes on jumping. So we need to understand that patients of CKD are going to land up with cardiovascular disease, heart failure, non-cardiovascular mortality, and therefore they need therapies which can address all these issues, not just the CKD alone. But again, a disturbing fact. This is US Healthcare Organization data, EHS, and if you see patients who have GFR less than 60, 80% of them did not have albuminuria test. And again, patients, again, we are again seeing a primary setting data. 93% patients were tested for GFR, only 56.4 tested for albuminuria. So it's not enough to do the GFR alone. In fact, most of our labs give only the creatinine values. I think the creatinine value, we all know, can be very misleading. It has to be calculated to the GFR value. We have beautiful apps, MDRD, EPI, CKD equations are readily available. You have to have the GFR value. And not just that, you have to have the albuminuria value as well. So it's very important all our patients, right from the diagnosis of type 2 diabetes, undergo an annual eGFR and USCR proteinuria estimation. If it is abnormal, it has to be done more frequently. Again, you see patients with diabetes, hypertension, only diabetes, only hypertension overall. People who are checked for GFR and proteinuria is much below what is acceptable. I think screening for GFR and proteinuria very important. The previous slide, beautiful that I showed you, but the x-axis is the albuminuria, y-axis is the GFR, and you stratify the patient's risk depending on what point of GFR and what point of albuminuria he fits in. Very important that these tests are done and patients are stratified and treated accordingly and aggressively. Right, so dual estimation of eGFR and USCR. You can use those equations I told you. EPI CKD is what we use commonly now. Cystatin C gives you further information. And albuminuria, again, very important. When you may use USCR, you use timed urine sample, you may use 24-hour urine sample. Also the urine sediment, electrolytes, uric acid. If required, you're suspecting a non-diabetic kidney disease, even histology doing a kidney transplantation, and of course imaging for unequal kidney size and renovascular and other kidney disease is also important. Not everything which happens to diabetes is because of diabetes, so you have to have a suspicion whether it's non-diabetic and even do imaging modalities also. So these are this is the standard of care. You need to have both the estimations along with the other estimations to know the cause of CKD and to treat them aggressively. Because we need to diagnose early and treat aggressively, because there is so much data available and so much evidence available that if you do an early intervention, you can add so many years to patient's life before he lands up with end-stage kidney disease and dialysis or renal transplantation. Late diagnosis, so early intervention helps preserve years without dialysis and renal transplantation. And no intervention versus late intervention. There are so many years which can be got by early intervention. So have a clinical suspicion very early, diagnose very early, and treat promptly and aggressively so that you can postpone patients to get into stage 4, 5 CKD and to get into dialysis and renal transplantation. So this is the zest of the matter, early intervention. And we know ACE inhibitor, ARBs were the standard of care till the evidence came from the kidney outcome studies of the SGLT2 inhibitors. We are going to see the DAPA CKD study in a little more detail a few slides later. Right, Declare TV. So basically, was the CV outcome study with dapagliflozin showed good reduction of renal outcomes in that study, almost 40 to 50% reduction of renal outcomes. But it was a CV outcome study. The renal outcomes were secondary outcomes, and the patients had a healthy GFR almost 80 plus. So they were very, very healthy kidney patients. Number of patients getting into kidney failure were low. That had to be replicated, and that was done in the DAPA-CKD study. So good to see about this data from the DAPA-CKD study. This was a study, and I'm really glad to inform you that I was an investigator from India in this particular study. We had about 200 patients from India, 4,000 patients across the globe. A very, very ambitious study, both diabetic and non-diabetic population included in the study, and dapagliflozin versus placebo on a baseline standard of care. Patients had to be on ACE inhibitor ARB stable dose for at least 4 weeks before they were enrolled in the study. And the investigators could not alter the dosages or stop the ACE inhibitor ARB unless it was for reasons of patient safety. That or then ACE inhibitor ARB was not tolerated in these patients because of hypotension and or hyperkalemia. So these were the study population. They were all on a very good, and 97% plus patients were on a good standard of care. And then they were randomized to either dapagliflozin 10 mg or a placebo or a matching placebo. Patients more than 18 years of age, GFR 25 to 75. So patients as low as GFR 25 were included in the study. Proteinuria 200 milligram to 5 grams per day. They were included. Patient had to be, as I told you, on a stable maximum tolerated dose of ACE ARB for 4 weeks. Patients with or without diabetes, significant number of patients did not have diabetes when they entered the study. Patients who had type 1 diabetes, patients with autoimmune disease, vasculitis, on steroids or immunosuppressive therapy were excluded from the study. Patients were randomized and mean follow-up of almost 2.5 years. The study was prematurely discontinued by the Data Monitoring Committee because of overwhelming benefits seen in the dapagliflozin arm versus the placebo arm. The primary outcome was a composite of kidney outcome of sustained GFR more than equal to 50%, and getting into CKD, which is measurement of GFR less than 15 or on 2 occasions, 3 to 6 months apart, or patients reaching dialysis or renal death or cardiovascular death, the primary outcome. Secondary outcome, a composite of renal outcomes minus the CV death, and composite of CV death HHF and all-cause mortality. These were the secondary outcomes of the DAPA. So this is a study design in short. And this is the outcome, the primary outcome. The primary outcome of composite of sustained 50% eGFR, applied ESKD, renal CV death, reduced in the dapagliflozin arm by overwhelming 39%. This was why the study was stopped prematurely. Overwhelming. The Credence study was published a couple of years before the study had shown overwhelming benefits. Also, this showed unforeseen benefits. Look at the p-value. How many times do you get an outcome study with a p-value of, what is it, 0.000000028? That is the p-value. So highly significant, statistically significant, 39% reduction of primary composite outcome with dapagliflozin versus placebo. And all patients and patients with or without diabetes both benefited from this, from progression of kidney disease. So it was consistent in patient with and without diabetes. Both the subgroups of patients benefited from this composite outcome. And look at the secondary outcome, composite of HHF CV death, reduced by 29%, significant p-value. All-cause mortality. Now this was the cake on the icing on the cake. The all-cause mortality reducing by 31%. Credence had shown good effect on renal and the CV outcome and the HHF outcome, but all-cause mortality reduced by 31% in the dapagliflozin versus the placebo. Huge benefits for CV death, hard outcomes. You're preventing patients from dying because of heart failure, dying because of any other cause by adding dapagliflozin to the standard of care. Patients who had GFR 25 to 45 at baseline, proteinuric patients with or without diabetes. So that was the outcome of the study. Right, and specific subgroups, these were pre-specified groups, patients having an IgA nephropathy. Significant number of patients in DAPA-CKD had IgA nephropathy. And the benefit in IgA nephropathy was 71% reduction of the primary composite outcome. 71% reduction. So that was the benefit for IgA nephropathy. New onset diabetes. Those patients of that who were without diabetes at baseline in the study, the number of patients getting into diabetes in the dapagliflozin arm was reduced by again 38% reduction of new onset diabetes in the non-diabetic population. You're getting wonderful benefits for the kidney, for heart failure, for CV death, all-cause mortality, new onset diabetes. This is the overview of the DAPA-CKD study. So more than 4,000 patients, randomized 1:1, 39% reduction of primary composite outcome. And look at that number needed to treat only 19. If you give 19 patients who have this particular sort of proteinuric CKD with or without diabetes, you give 19 patients of this drug, you are going to save one patient for getting into dialysis, dying because of kidney or kidney or renal death. You're going to prevent one patient of these 19 patients to land up with end-stage kidney dialysis, renal death, CV death, renal transplantation. 19 patients. As low as 19 patients, you give this drug, you're going to prevent one from getting into. Look at the reduction on all-cause mortality, a reduction of renal outcome minus CV death, and reduction of CV death Hfref. Highly significant p-values all across the place. So you are giving this drug to this high-risk population. You are preventing the renal disease from progressing. You are preventing them from getting into dialysis. You're preventing them from dying of kidney or cardiovascular death. You're reducing Hfref, CV death. You're reducing renal outcomes. You're reducing all-cause mortality. Very hard hitting. A study which has revolutionized the treatment of type 2 diabetes. As I told you, ACE inhibitor was and ARB is a standard of care, which was the studies which for these were done more than 20 years back. There was nothing in between, and now you have this data initially with credence for canagliflozin, and now DAPA CKD. You have data with dapagliflozin. The EMPA kidney study has also been prematurely discontinued just last month for again good benefits in the dapagliflozin arm. We're yet to get the full results of that study, but SGLT2 inhibitors in general and dapagliflozin in particular have redefined the treatment of CKD and to prevent patients from progressing to end-stage kidney disease and getting into dialysis and CV death Hfref. So even the safety profile was very good. See, the other SGLT2, what I like about dapagliflozin, and this I tell in various talks of mine, is that the safety profile is well established. You don't have any issues like fracture and toe amputation as with canagliflozin. You don't have any issues with increased stroke as with dapagliflozin. Absolutely clean, clear data available. We were as investigators told to monitor for these, specifically for these adverse effects of fracture and AKI and even Fournier's ganglion and even toe amputations. No increased risk with in a high-risk population as this safety absolutely established. Even no major hypoglycemia in patients without diabetes. That again is a concern to some people. If I give it to a patient without diabetes who qualifies for it, now dapagliflozin has an extended label indication for heart failure, diabetic and non-diabetic population. After the DAPA-HF study, it has also got an indication for slowing the progression of kidney disease (CKD) in both diabetes and non-diabetic population. So, if you give it to non-diabetic population, you do not increase the rate of the risk of hypoglycemia. No DKA events, no AKI, no major AKI events, no issues of fractures and low limb amputation. Study was stopped early, unforeseen benefits. All-cause mortality benefits not seen in any of the other studies, CV outcome study or renal outcome study. DAPA-CKD happens to be the only outcome studies with the cardiovascular renal outcome of studies, which has shown or reduction in all-cause mortality, and not just a minimum reduction, a 31% reduction of all-cause mortality, and even the secondary outcomes of the heart, across the spectrum of diabetic kidney disease. Now, patients were stratified. DAPA-CKD patients also stratified patients as per GFR and as per the proteinuria. Patient was stratified, patient proteinuria more than 1 gram or less than 1 gram. At the beginning, they were also stratified as per GFR, GFR more than 60 or less than 60 at the baseline. All GFR, across the GFR spectrum, all the patients got benefit of all these outcomes across the spectrum of diabetic kidney disease. So so basically dapagliflozin is the only molecule as of now, which now canagliflozin does not have data for heart failure. Empagliflozin data for kidneys is yet awaited. It took about 6 months for the full data to be available. The only drug SGLT2 inhibitor which has the CV outcome data, the DECLARE TB, more of a primary prevention cohort, 2 out of 3 patients more of primary prevention, only 1 of secondary prevention. Showed you 17% reduction of CV death HHF, 27% reduction of HHF, 47% reduction in the renal outcomes. That is what I told you, 40 to 50% reduction there. That prompted the DAPA-CKD study, which I have told you in detail. The DAPA-HF study, again, both diabetic and non-diabetic population, showing the primary composite outcome reduced of CV death HHF, urgent HF visit to the emergency room reduced by 26%. And again, that also showed a 22% reduction of new onset type 2 diabetes. DAPA-CKD, I think the numbers are overwhelmingly positive for our patients getting the benefit of drugs for MACE benefits, for heart failure benefit, and for kidney benefits. Right. So you have the prevention study that DECLARE in the CV outcome study. You have the DAPA-HF treatment study. I think the HF speaker has taken us through how paradigm shift. There's a paradigm shift in the treatment of HF-REF after the data available from DAPA-HF, and I've told you about the DAPA-CKD study. So again, huge benefits for all-cause mortality, primary kidney outcomes, secondary heart outcomes, and even new onset of diabetes. So the data from all these studies, especially the DAPA-CKD, has prompted for various organizations like the European Renal Association, the Dialysis Association, to redefine the place of SGLT2 inhibitors in patients with CKD, with diabetes, not on goal SGLT2 inhibitor like dapagliflozin, with proven benefits, with evidence of cardio and nephroprotection benefits, comes high up there. GLP-1 receptor agonists have shown some benefit, but remember the GLP-1 receptor outcome studies have shown benefit in reduction of proteinuria. That reduction is not in hard kidney outcomes like transplantation and dialysis and end-stage kidney disease, and it's more in for proteinuria reduction. Again, patients already on anti-diabetic drugs, and he's even on target, less than A1C7. Even then, you can substitute with the other drugs, switch over to an SGLT2 inhibitor with proven cardio benefit like dapagliflozin. Irrespective of the HbA1c, one can give this drug for the renal benefits as per the various guidelines coming in from the renal associations as well. We have seen the guidelines from the heart associations, the ESC and the AHA. These are the guidelines from the renal associations across, and clearly saying SGLT2 inhibitors, even very early for patients, especially patients who are albuminuric, can have a GFR below 60. Right. So this is the various, again, just looking at the guidelines, and here seeing again the lifestyle modification continues. Metformin, when you have GFR less than 45, reduce the dose to less than 1 gram per day, and your patient gets GFR less than 30, you stop that. Do not start below 45. If patient is already on metformin, reduce the dose, and below 30, you stop metformin altogether. SGLT inhibitors, right up to 30 GFR, you can give the drug. Now remember, the higher GFR when you use an SGLT2 inhibitor, you will get the cardiorenal benefits plus the diabetes benefit, because the GFR is good, the filtration of glucose is going to be good. You're going to get good weight loss, you're going to get good A1C control. At a lower GFR, you will not get the anti-diabetic benefits. The glycosuria may be less because the GFR is none, but you continue to get the cardiorenal benefits even up to 30 GFR. In fact, the KDIGO and other organizations are now recommending you can go right up to dialysis with the SGLT2 inhibitor and discontinue only when your patients are dialysis. As I told you, DAPA-CKD study enrolled patients right up to GFR of 25. EMPA-KIDNEY, the Credence study which came before, included patients only up to 30 GFR. Credence, the study did not have non-diabetic patients. They were all diabetic patients, canagliflozin or matching placebo. DAPA-CKD had non-diabetic patients, went up to 25 GFR for enrollment. EMPA-KIDNEY also has non-diabetic patients, goes up to 20 GFR for enrollment. We are yet to get the results of the EMPA-KIDNEY study, but I think we can continue the GFR very soon. We're going to get guidelines where you can continue the patient up to dialysis with SGLT2 inhibitor like dapagliflozin. Do not initiate with less than 30, but maybe after the results of EMPA-KIDNEY, this also guideline is set to change to a much lower value, maybe up to 20. So use the agent with benefit. Prioritize agents with documented and cardiovascular. That is where I've shown you dapagliflozin is the only molecule as of now which has a dedicated heart failure study, the HF, DAPA-HF for HF-REF patients, the DAPA-CKD study, and the DECLARE TB study. So if you further down, you can go for a GLP, again, putting the benefits. DPP-4 more safe for hypoglycemia, you can use the other agents as well. So clearly, SGLT2 inhibitor comes way up there in the various guidelines. Again, this is KDIGO 2020 kidney disease, improving global outcomes, and you screen the patients which have risk factors, the various risk factors given here, especially diabetes, hypertension, again, other comorbidities, screen with GFR and with GFR and albuminuria, and then stratify the patient. Once you screen and you get the values over here, so if especially your patient is less than 30-60 GFR or more than 30 milligrams per grams of USCR, you stratify the patient. You stratify the patient, assign the eGFR and the albumin category, use that beautiful tool over there, which I've shown you, where you can put the GFR and the albumin category and stratify your patients as low risk, moderate risk, high risk, or very high risk. And then if patients gets a GFR below 60, you need to address the other drugs, your anti-diabetic drugs requires no adjustment. You need to again, NSAIDs. One of the worst things for patients less than GFR can be NSAIDs. I think so many of our patients take these drugs over the counter and land up with rapid progression of kidney disease with falling GFR. You see, GFR normally falls with CKD 2-3 mL per year. Some of your patients getting NSAIDs and other nephrotoxic drugs can drop almost 10 mL of GFR every year and land into early renal stage 5 CKD and dialysis very early if you use the nephrotoxic. So again, important to patient to hand out a chart of the nephrotoxic drugs and to tell them to stay away from these drugs, and dose adjustment for anti-diabetic drugs like metformin. I told you that. Aggressive treatment of hypertension, diabetes, and various comorbidities. Pneumococcal vaccine, influenza vaccine, screen for hepatitis C. And once they get into further, they are very high risk for cardiovascular disease, heart failure. Aggressive statin therapy, aggressive BP lowering therapy is very, very important. So basically multi-factor intervention, avoid nephrotoxic drugs, repeated testing to see if they are progressing further down to stage 3, 4, 5 CKD. This is the algorithm for aggressive treatment of CKD by the KD. And then, last but not the least, SGLT2 inhibitor like dapagliflozin as a first line with metformin with patients with CKD, with or without diabetes. So, doing both over here, the USCR and creatinine very important. Stratifying their risk is very important, and SGLT2 inhibitor like dapagliflozin very important. And standard of care, of course, ACE inhibitor ARB is there. Heart failure, there are so many drugs which one can use, and as the earlier speaker have elucidated, the issue is now which drug to start with, how to do the sequence of drugs. Fortunately, in patients with CKD, that is not an issue. After ACE inhibitor ARB, standard of care, it is the SGLT2 inhibitor. So, large number of patients again do not tolerate the ACE inhibitor ARB because of hyperkalemia and or hypertension. Again, for those patients, SGLT2 inhibitor is a good. In fact, on top of the ACE inhibitor ARB, the benefits which I showed you for DAPA CKD state are on top of the baseline treatment of standard of care of ACE inhibitor. So identifying patients and early intervention can slow disease progression, preserve kidney function, and reduce complications. Preservation of nephron, the idea of nephron preservation, nephron protection is come up very strongly with the advent of SGLT2 inhibitors and the huge data which is available from the studies like DAPA CKD. So check albuminuria, kick off a conversation with the patient, inform the patient GFRs are dropping, need to avoid nephrotoxic drugs, need to see a nephrologist, diagnose early, treat effectively, good standard of care, SGLT2 inhibitor. And all this, we can slow the progression, give your patients years of life without dialysis or transplantation or renal death, or even for that matter, cardiovascular death, by effective use of drugs like dapagliflozin. So, the indications, various indications, apart from an anti-diabetic drug, dapagliflozin has an indication for patients with established cardiovascular disease to reduce risk outcomes, patient with HFrEF, both diabetic, non-diabetic, to reduce the hospitalization of heart failure and CV death, and patients with kidney disease and albuminuria, both diabetic, non-diabetic, to slow the progression of kidney. So the atherosclerotic benefits, heart failure benefits, and the kidney benefits seen across the studies with dapagliflozin, and therefore there is a label indication for dapagliflozin for all these indications. For all these indications, so basically a very broad range of patients can benefit from dapagliflozin if used correctly and if used very early, to give all these benefits to our patients. And independently of baseline, in diabetic patients, independently of baseline, there's a compelling indication to use dapagliflozin in this particular population. Right, so we have a lot of generic dapagliflozin available. A last couple of minutes on the generics. The drug development program, as I told you, I've been a part of large global trials, phase 2, phase 3 as well. Apart from the DAPA CKD study, it takes huge efforts, huge number of years, and huge finances to go through the various trials and to generate the data which we have seen over the last 2-3 hours. We have seen the data with dapagliflozin for heart failure, for atherosclerotic outcome, for kidney outcomes. It takes huge efforts and finances and time to generate the data. And that is why the data which is generated from the innovator, can it be extrapolated to the copies which comes in the market after the patent goes away? That is the big question. So it's a huge process, 10 to 15 years required for a drug to get into the market and to generate the sort of data which is available with dapagliflozin. And that is the amount of money required, billions of dollars, get into a drug development program. And what happens is when the copies have to just show the bioequivalence. But is the pharmaceutical equivalence equal to bioequivalence? And is bioequivalence equal to therapeutic equivalence? Those are the questions which need to answer. And we need to use the innovator drug to get the various benefits that are shown in the outcome studies, especially for the heart and the kidney. Because again, there can be a lot of enantiomers, there can be a lot of stereogenic changes in the drug. The original dapagliflozin has 5 sterogen centers, and even a change in 1 or 2 of these centers can affect metabolism, potency, safety of the drug. Right. So the generic versions do not have data for cardiovascular system renal outcomes, and they may have data, they may be good for the control of sugars and diabetes. But as far as the cardiorenal benefits are concerned, I think the innovator drug should be trusted because it's the patient's cardiovascular and renal outcomes and mortality, morbidity and mortality which at stake. So we should, if you ask me, at least for the cardiorenal indications, one should go by the evidence with the innovator. To summarize what I have spoken in the last half an hour, we have seen the prevalence and burden of CKD all across the world, and how diabetes, hypertension contributes a major chunk of the patients with CKD as an etiology. We have seen the DAPA CKD study with more than 4,000 patients. significant gap in therapy after his inhibitors has been addressed with the data, with the benefit on renal outcomes, cardiovascular outcomes, all-cause mortality, heart failure. So all the evidence would declare DAPA-HF, DAPA-CKD, huge cardinal benefits, mortality benefits with dapagliflozin to all these high-risk patients. So thank you so much for the patient listening.
Thank you, Dr. Kadam, sir.
Yeah, thank you, Dr. Kadam. That was an excellent presentation. And all of us here in boardroom are actually listening very intently to your presentation, because I think it was the most practical presentation. And you know, Dr. Alka is already under your treatment. So she was guiding us as to what were the important points in your talk.
Right.
So that was a nice one. Yeah.
Thank you. Thank you.
Thank you, sir.
I request our President, Dr. Meenakshi Deshpande, Madam, to felicitate today's speaker.
Yeah, so from the whole of IMA Pune team, we would like to felicitate you with this Uparna and a bouquet. And we are actually here, 5 of us are here. I would invite everybody of us to join. So please come. We are having our Shahade sir with us and MMC observer Dr. BL Deshmukh also. So the whole team of IMA Pune is here now today.
Yeah. Whole team charge entire team.
Oh, entire
Right.
So thank you, sir.
Yeah, thank you so much.
Yeah.
Whole team
Thanks, Madam, thanks.
Yeah, thanks.
Formal vote of thanks for today's webinar on cardiac pharmacotherapy. At the outset, I thank all the speakers and delegates for participating enthusiastically in today's webinar on cardiac pharmacotherapy. I also thank our MMC observer, past president, Dr. BL Deshmukh sir, for sparing his valuable time and coming here. I thank AstraZeneca for the academic grant. I also thank DigiShield for the technical assistance and IMA support staff for flawless audio-visual connectivity. Once again, I thank everyone for this cardiac pharmacotherapy webinar. Thank you.
Thank you. With this, we will conclude. Thank you. Thank you. So with this, we conclude, and we also invite all the members for 29th May walkathon. We are listening to diabetes so intently that we are forgetting our own fitness many times. So I will request all the IMA Pune members, whoever are still listening and on to their audio is on, please come on 29th May at 6:30 AM morning near Rajendra. Rajarampur. Opposite Matoshri Mauli Vruddhashram. Matoshri Vruddhashram, yes. So come at 6:30 AM on 29th May Sunday. So bye from IMA Pune. Thank you. Thank you.
Thank you to all the speakers. Thank you so much. Thank you, sir.
Thank you, sir. Thank you, Amy.
Thank you, IMA. Thank you to eminent speakers.